Good evening, good afternoon, and good morning. Welcome to the second session of Kerala International Health Webinar Series. The theme for this series is Making SDGs a Reality. The webinar series have been organized by the Department of Health and Family Welfare, Government of Kerala. Our knowledge partners are the World Health Organization, UNICEF, and the World Bank. We have 5 in the series. The sub-themes for the theme are 1. Universal health coverage moving towards better health. That session just concluded yesterday. It's available on the Facebook and YouTube. Today's is COVID-19 pandemic, health system response, resilience, and preparedness. Our next series would be on Achieving Sustainable Development Goals related to maternal mortality and infant mortality. Is it a dream or a reality? It will happen on 24th February. Meet the SDGs and beat the NCDs. Sounds rhythmic, but a top priority of Kerala, especially in the COVID context. It's scheduled for 25th February. And the last in the series is Moving Towards Tuberculosis Elimination, a call for action, again from the Kerala perspective. This will happen on 4th March 2021. COVID-19 pandemic, health system response, resilience, and preparedness. That is today's theme. Response to COVID-19 pandemic is an inevitable topic in this webinar series organized by the Government of Kerala. We have scheduled today's topics in such a way that we will go through the journey of COVID-19, starting from the first case reported in China. We begin with the global perspective, the response from the global side presented by the WHO technical lead on COVID-19, Dr. Maria Van Kerkhove. Role of Indian Council of Medical Research in the fight of India against COVID, that will be presented by Dr. Baldam Bhargava. Kerala's response to COVID-19 pandemic presented by Kerala team, Dr. Rajan Kobragade, our Principal Secretary leading Team Kerala Health. We will have Dr. Sakina, District Medical Officer, Malappuram, Dr. Sandhya, District Surveillance Officer, Kollam, Dr. Raman, District Program Manager, Kasaragod, Dr. Aravind, Head of Infectious Disease Medical College, Trivandrum, and Dr. Dilip, KMSCL, Medical Service Corporation Director, Managing Director. From Kerala, we will move on to some of the international topics. Crisis leadership and workforce resilience. This will be presented by Dr. Ajit Abraham from the National Health Service, United Kingdom. And there is also a set of responses from our collectors, district collectors, and this will take us through Kerala's journey on how our other systems responded to the pandemic. This will be led by Dr. Ratan Kelkar, the Mission Director of State Health Mission, and the collectors, Dr. Navjot Khosa from Trivandrum, Dr. Mr. Suhas from Ernakulam, and Dr. Adila Abdullah from Wayanad will join Dr. Ratan Kelkar. The ultimate aim of this webinar series is to share experiences, learn together, and most importantly, gather information, and from this knowledge, translate that in our journey forward. For that, we have 2 special sessions. One, we are extending the scope of this webinar into preparedness in terms of pandemics in general, and we have 3 eminent speakers for that panel. Dr. Gagandeep Kang from CMC Vellore, Dr. Jacob John again from CMC Vellore, and Dr. David Wilson from the World Bank. All throughout the sessions, Dr. Raman Gangadkhetkar, the epidemiologist of ICMR, will be with us, and he'll talk to us finally on the epidemiology analysis and the next steps for control of COVID, especially from Kerala's perspective. We have an outstanding lineup for today's webinar series. Please stay with us all throughout. We are beginning the first session. May I now invite Mrs. K.K. Shailaja, our Minister for Health and Social Justice, to preside over the first session. Madam, please come to the dais. May I now invite our chief guest, Dr. Maria Van Kerkhove, the technical lead of COVID-19 at the World Health Organization. She is joining us online. Welcome, Dr. Maria. I now welcome Dr. R.L. Sarida, our Director of Health Service, and Dr. Ramla BV, Director of Medical Education, Kerala. May I now invite Dr. R.L. Sarida for the welcome address.
Honorable Minister for Health and Social Justice, Srimati K.K. Shailaja teacher, distinguished dignitaries on the dais and off the dais. Warm good evening to all of you. It's my pleasure to welcome the brave marshal of Team Health Kerala, who has kindly consented to preside over today's session on COVID-19 pandemic, health system response, resilience, and preparedness. She is none other than our most respected Minister for Health and Social Justice, Kerala, Srimati K.K. Shailaja teacher, who proved that leadership is action, not position on the global stage. The next distinguished personality to honor us with her presence today is, as the chief guest is Dr. Maria Van Kerkhove, COVID-19 Technical Lead, World Health Organization. Welcome, Dr. Maria, to this evening. We would love to hear from you about the global response of health system to COVID-19 pandemic. Today's audience are really blessed to hear from Professor Balram Bhargava, Director General, Indian Council for Medical Research, Government of India, Dr. Ajit Abraham, Dr. Gagandeep Kang, Dr. Jacob John, Dr. David Wilson. Welcome all the eminent speakers to this evening. District administrations of Kerala have been doing tremendous work in coordinating and implementing various activities during the pandemic for the past 1 year. Dr. Navjot Ghosa, IAS, District Collector Trivandrum, Dr. Suhas S, IAS, District Collector Ernakulam, Dr. Adila Abdullah, IAS, District Collector Wayanad, along with Dr. Raman Khenga Kedkar, Head of Epidemiology, retired ICMR. They will be sharing a bit about this unique experience. Welcome you all to this evening. Last but not the least, I would like to extend warm welcome to Dr. Rajan N. Gobrede, our Principal Secretary Health, Dr. Ratan Kelkar, Director NHM, Joint Secretary Health, Dr. Sriram Venkataraman, Dr. Ramla Baby, DME, and all my colleagues in the health. Of course, some of them are speakers of the day. And all the well-wishers who are already logged in to this webinar, waiting eagerly for this academic feast. Thank you. Thank you all. Ma'am, please preside over the function.
May I now invite our Honorable Minister for Health, Mrs. K.K. Shailaja, for the presidential address. She is also the Minister for Women and Child. It may be coincidence that we have all women on the dais now. Again, we have Dr. Maria on the technical lead at the WHO. Actually, Dr. Soumya Swaminathan again is the chief scientist. Maybe a coincidence. Shailaja madam is really affectionate, but she's the efficient captain of our health system who takes us through the turbulent times of COVID-19, equally focusing on building up the systems through Ardhram mission, which we listened to yesterday, and focusing on all areas of health care, not just COVID-19. Over to you, ma'am, for the presidential address.
Thank you. Dear friends, we are indeed fortunate and excited to have Dr. Maria Van Kerkhove, COVID-19 Technical Lead, World Health Organization, and Professor Belram Bhargava, Director General of Indian Council of Medical Research and DHR, Government of India. At the outset, let me take the liberty to congratulate both of you for your tremendous work and leadership you have been rendering in this historic fight against the pandemic of the millennium. As we all know, COVID-19 has been a litmus test for the health system preparedness, response, and resilience, and even overall governance for almost all countries across the globe. We have witnessed that while many affluent or rather high-income countries with well-resourced health system wrecked in the storm of the pandemic, many low and middle income countries and few states of provinces within them set new models and taught new lessons. The disparity in the response to pandemic among the countries and the states begins from identifying the cases, reporting of the cases, or even definition of the deaths due to COVID-19. And of course, in the robustness of surveillance system and effectiveness of medical and social support mechanism. This often results in gross surveillance bias when we compare between responses. However, there are few indicators which provides a reasonable evaluation when adequately fed with data. Yesterday, I was going through the world mortality data set done by few eminent universities across the globe, which tracked excess deaths across the countries during the COVID-19 pandemic. They evaluated the excess death during the pandemic period with reference to the same period in the previous years. Of the 77 countries evaluated in the study, 51 of them had significantly high number of excess deaths during the pandemic year compared to the previous years. This relative increase is highest in Peru. I think it is with 73% increase in excess death with reference to previous years, while it is around 14% increase in USA and 13% in UK, to cite a few. What is interesting is that in 6 countries, total deaths, that is all-cause mortality, actually decreased during the pandemic period. Obviously, in best-performing nations like New Zealand, the deaths decreased by around 6%. It is in this context that the excess death analysis done in the state of Kerala holds strong and really encouraging thing. Excess death analysis done based on the data from the comprehensive and universal health registration in the state, death registration in the state, showed all-cause mortality in the state decreased by over 10% during this pandemic period, 2020, when compared to 2019. This is indeed very exciting and motivating for my whole team in the state, given the fact that we had many demographic and epidemiological vulnerabilities. As you all know, Kerala is in the first place for several health indices. Our child mortality rate is very low comparing to other places of India, and our mortality rate is also very low, and the life expectancy is high comparing to other states of India, and comparing to the developed countries also, we are very near to the developed nations for the life expectancy, etc. But amongst the advancement of health system, we have so many challenges we have to face, some vulnerabilities we have to face during a pandemic period. We have to face the demographic and epidemiological vulnerabilities. On part of demographic vulnerabilities, as you know, Kerala is a thickly populated state, and our population density in Kerala is 860 for 1 square kilometer. And it is 430 is our national average. Then you can imagine how we have to face the challenge during a pandemic like the highly spreading pandemic like COVID-19. And the other thing, on one part, it is an advancement that the old age population is very high in Kerala. Almost 15% of the total population. But during a pandemic season, it became a great challenge to protect these old age from the virus. And we have to adopt some techniques, some methods to prevent the virus to the old age population, to get into the old age population. And other epidemiological vulnerabilities are also here. Because of our lifestyles, Kerala changed its lifestyle very much during these years. Kerala's Human Development Index is too high, and the lifestyle also changed of that, but it is not a positive change because of the food habit and without any physical exercise. Kerala is, I think it is not a famous thing, but we are known as the non-communicable diseases, or the lifestyle diseases are high in Kerala. Kerala is known as the diabetic capital of our country. That is also a great challenge during this COVID situation, COVID pandemic. We have to take care of not only COVID patients, but also the high morbid, comorbid patients, or those who have lifestyle diseases, to prevent the virus entering to that section of the society, to prevent death or reduce mortality rate. And we were working hard. We were fighting against these challenges, epidemiological and also demographic challenges. And amongst these challenges, we achieved this thing, that the all-cause mortality in the state decreased by 10%. We are enthusiastic to having such a very good result out of our hard work during this 1 year, or during the year of the pandemic. One of the primary factors which led to this significant achievement is the basic and decentralized public health initiatives and interventions we undertook during the period, especially our Break the Chain campaign. We adopted some strategies of our own, or we set some models for work for against the pandemic, because I think in India, the pandemic came first to Kerala, just after Wuhan. Some Wuhan returnees brought the virus here also, and we started our work from January 30th, 2020. Throughout this 1 year, I think Kerala has one of the long drawn pandemic throughout the world. Throughout this 1 year, we were fighting against the pandemic. We adopted some strategies. The first strategy is to break the chain. How to break the chain of transmission of this virus, highly infectious virus. We asked the people, or we campaigned to use masks and to use soap or sanitizer, to wash hands, and also keep distance. SMS campaign, that is a very good campaign conducted in our state. Soap or sanitizer, mask, and social distance. And I think 80% of the people, this campaign reached them and they obeyed. But as usual, 20 or more percent, they are not obeying, and they are jumping quarantine, or they are not obeying this SMS campaign. But we succeed in that campaign. That is why we can break the chain, and we can reduce the spread and reduce the mortality rate also. For the testing method also, we adopted a scientific strategy. We are not omitting any of the cases who have symptoms. All the symptomatic cases we are testing, even in our primary health centers. We advanced, or we improved our primary health centers during these 5 years. that we adopted a mission in health sector called Ardram. Through that mission, there are so many advancements in private sector, primary sector, not only primary, secondary and tertiary sectors. Hospitals are also improved a lot. In the primary sector itself, we are trying to tracing this virus or the symptoms. All the ILI cases, all the SARI cases that will definitely, we are asking them to report to the primary health center, and we are testing in each and every primary health centers. Now we are calling family health centers. They are reporting, they are testing all the chronic obstructive pulmonary diseases and all the ILI SARI cases. That where we are tracing and we are quarantining. After that, when symptoms occurs, we are testing. If any clusters occur in any places, we are testing the whole society, and we are increasing the number of tests, and we had proper number of tests here. Sometimes someone suspect that the testing number is low in Kerala. I cannot say so. We cannot say so because the test per million in Kerala is a very good number. 1,85,000 and more. That is not a bad thing. That is a very good number, sufficient testing. But each and every time where any cluster occurs or anything happens peculiarly, we are increasing the test all of a sudden, and we are doing proper test. For the testing strategy, we adopted a scientific manner, and each and every symptomatic cases, we definitely test them and identify them and isolate them and treat them. That was our method, and that method is following now also. Trace, quarantine, test, isolate and treat. That also reflected in the recent sero surveillance study done by ICMR. It is clearly evident from the sero survey that even after being the first state to report COVID-19 case, Kerala is the last state to peak with the latest sero prevalence of just 11.6%. By dealing this pandemic, during this situation, the science world is asking or imagining to delaying the peak of the virus. We can adopt two methods. It is the problem is, or the question is, what method you are going to choose. Either we can choose the mitigation method, allowing the virus to enter the whole society and to get a herd immunity out of that. Another is to slow down the transmission of the virus, slowing down the peak, and protect people from this virus, and to wait for a good day or a positive time that a vaccination will come, and at that time we can give artificial immunity by vaccination immunity. And the question is, what is the choice? We choose the prevention or containment, or to reduce or to lower down the peak of the virus. Slowly the peak occurred in Kerala. Even though Kerala was the first state which reported the COVID-19 virus, Kerala is the last state to get the peak. Because of the SMS break the chain campaign, because of the reverse quarantine, because of the testing method, each and every institutes and each and every place where people are living together, we were testing throughout this time. Because of that, we can delay the peak. And the peak occurred in Kerala later. And that also, I think we can have a control over it also. Because the Kanpur IIT and other institutes predicted that when the virus entered to the society, when the lockdown was lifted once, at that time, Kerala had to face more than 20,000 positive cases per day. Because here it is a thickly populated place, and we have to face more than 20,000 cases per day. We really afraid of that thing. And we started our work, our team, our Secretary Rajan Gobrigade IAS, and our DME, DHS, and doctors, eminent doctors like Dr. Indu and everyone. The teamwork, because of that teamwork, the number of the cases never reached to that mark. It goes up to 10,000 or more. But after that, we tried our best and the peak again become low, slowing down the peak. It happened here. And now per day, 5,000 or 6,000 cases are reporting here. That is not a frightening thing. We should have to listen everything and we should be attentive. We should have to cautious on these things. But anyway, it is manageable. And now the peak is going down, but we are too vigilant because the local body elections are over. The assembly elections are coming. There are gathering of people here. We are working hard to delay the peak or reduce the peak. And we are working for a much more good result on that. That is exactly why our system, for that matter, health systems across the globe needs to resilient to the pandemic fatigue and to be better prepared for facing the newer challenges. Pandemics or infections with pandemic potential will emerge in various parts of the globe again soon or later. And it's our collective responsibility as humankind to build systems and partnerships to deal with them effectively. Because just like Spanish flu of the last century history gives us opportunity for revolutionary reforms and changes just once in a century. So let's grab the opportunity to make a more resilient and better prepared health system and partnerships at all levels. With these words, I announce this session is opened.
Thank you, ma'am. Kerala lovingly calls her Shailaja teacher. These days, her speeches reminds us that she of a teacher in public health. Basically, she's a physics teacher, but as a health minister, I think she has learned a lot of public health in depth so that she quotes data and interprets and analyzes with such ease that, you know, similar to her competencies as an administrator, she has become really excellent in public health as well. Thank you very much, Shailaja madam. May I now invite Dr. Maria Van Kerkhove to address us. She's a technical lead of COVID-19 response and head of emerging diseases unit at the WHO. She is an infectious disease epidemiologist and has a PhD from the London School of Hygiene and Tropical Medicine. She was earlier a senior research fellow at the Imperial College London and head of outbreak investigation task force at Pasteur Institute of Global Health. She specialized in emerging and re-emerging diseases such as Ebola, Zika, and MERS-CoV. Dr. Maria, we are really privileged to have with us in the scientific session. Please speak to us on COVID-19 health system global response. Over to Dr. Maria.
Hi, my name is Maria Van Kerkhove. I'm an infectious disease epidemiologist with the World Health Organization and also the COVID-19 technical lead. Thank you for the opportunity to speak with you today. I just wish I could be with you in person. For the next few minutes, I'm going to give you a global overview of the COVID-19 pandemic, the current situation that we are in, and an overview of some of the elements of the pandemic response to date. I wish you all the success in the conference that you are attending. What you can see in this global epidemic curve is an overview of the epidemiologic trends since the beginning of this pandemic. From the 31st of December, 2019, when WHO was alerted of a cluster of pneumonia of unknown etiology in Wuhan, China. From then, from the 1st of January, 2020, we activated our incident management team, and we have been operating nonstop since. Within a few days, we issued our first alert through our EIS system and our disease outbreak news. And within 2 weeks, we had issued a full package of technical guidance for how to find cases, how to collect samples, how to protect health workers, how to care for patients, a whole overview of what needed to be done to really find where this virus is. On the 30th of January, the WHO Director General, Dr. Tedros, declared a public health emergency of international concern, the highest level of alert under the international health regulations. And within a few days after that, we issued our first strategic preparedness and response plan. Since then, you can see an overview of the trends by region. You can see in color there, and as of the 16th of February, we have had more than 108 million cases reported to date, which is likely an underestimate of the total number of cases infected, and more than 2.4 million deaths. On the bottom of this slide, you can see some key events in recent months. But if we look at the regional picture, there are very different epidemiologic pictures by region. And even within a region, there are very different types of transmission that are occurring in individual countries. But we are, in general, seeing a decline in cases. And we have seen a decline in cases over the last 5 weeks. We've also seen a decline in deaths in the last 5 weeks. And this is true across all of our regions. We do see that there are different transmission situations in countries that countries have faced since the beginning of this pandemic. And we can break these down into 4 different categories. We see some countries that have really avoided large outbreaks, not allowing the virus to really seed in their country and take off. We've seen a number of countries that have had one major outbreak, which they have brought under control, and seen maybe small levels of resurgent and small outbreaks here and there. We've seen a number of countries that have had major outbreaks, which they have brought under control, which are seeing resurgence. As societies have opened up, they've seen cases increase. And we have seen some countries really deal with a lot of intense and ongoing transmission. Having said that, we still do see countries around the world seeing a general decline in cases. And this is good because this is showing us that the public health and social measures that are implemented work. On the 4th of February, 2020, WHO issued the first strategic preparedness and response plan. And this was the global strategy for COVID-19, focusing on 3 major elements: to suppress transmission, to prevent as many infections as we could, and for those who are infected, to prevent onward spread; to protect the vulnerable, so to make sure that those who are most vulnerable do not get infected with this virus and prevent amplification events; and to save lives. These 3 elements are the core of the Strategic Preparedness and Response Plan then, and they remain the core of the Strategic Preparedness and Response Plan now. This slide gives an overview of the global strategic objectives that we issued last February, and again, they remain the same now: to suppress transmission, save lives, and to save livelihoods. And we outline here on this slide all of the actions and objectives that are necessary to achieve suppression of transmission, to save lives, and to save livelihoods. This includes mobilizing all sectors and community, all sectors of government and society, so that they take ownership and that they are enabled and able to participate in the response and in preventing cases through hand hygiene, through respiratory etiquette, through individual level physical distancing, to control sporadic cases and clusters and prevent those cases and clusters from becoming community transmission by rapidly finding and isolating all cases, by providing all cases with the appropriate level of clinical care, making sure that we carry out contact tracing of those who are in contact with an infected individual, providing supported quarantine of all of those contacts, making sure that we suppress community transmission through context-appropriate IPC, or infection prevention and control measures, population-level physical distancing measures, and appropriate and proportionate restrictions on non-essential domestic and international travel, to reduce mortality by providing appropriate clinical care for those who are affected and infected and develop COVID-19, the disease caused by SARS-CoV-2 infection, and ensuring the continuity of essential medical and social services, protecting frontline workers, critically making sure that we protect and train and provide supported work environment for our frontline workers and protect vulnerable populations. And lastly, to develop safe and effective vaccines and therapeutics, which can be delivered at scale, making sure that those are available to all of those in need. What you can see in 2021 are the elements of this integrated response. All of the pillars from laboratory and diagnostics, surveillance, contact tracing and isolation, making sure that we tackle the infodemic, making sure that we have enabled communities, we have good infection prevention and control, we maintain essential health services, we have good travel, trade, and points of entry guidance, and now we have vaccines, and more importantly, vaccination. All of this is underpinned through coordination and planning, making sure we have strong operational support and logistics, and that we accelerate research and innovation. What is really critical, though, is that we get vaccines to those who are most in need. And that includes people who are at risk for severe disease, people of older age, and our frontline workers. But everything that we do is underpinned by science. Science drives our understanding. It did in the beginning, and it continues to do so now. More than a year ago, we knew nothing about SARS-CoV-2, and now we know so much related to the disease that is caused by those that are infected with SARS-CoV-2, the disease that develops. We are starting to learn about long COVID, the long-term effects from those who are infected with this virus. There's much work underway to have proper research and rehabilitation for people who are suffering from long COVID, and making sure that we understand mortality and the drivers of mortality. And so there's a lot that we are still continuing to learn about that. Transmission is another factor that we continuously learn about. And we understand from transmission from the beginning the importance of the intensity, the duration, and the context of the exposure. This is what is driving our understanding of transmission. And context matters. Trying to understand when people transmit, because we know people without symptoms and people with symptoms can transmit this virus. From the viral shedding data, it appears that people are most infectious at or around the time they develop symptoms, including very mild symptoms. And that includes the 2 days just before they develop symptoms, up through the first 5 to 7 days of infection for those who are, or the first to 5 days of illness for those who have severe mild disease, and it can be up to 3 weeks where people who have severe disease. But we're still learning a lot more about secondary attack rates and different settings in which transmission can be amplified, because this virus operates in clusters. We know that approximately 10 to 20% of all cases are responsible for about 80% of all transmission events. And that means not everybody transmits the virus. There are certain settings in which transmission can be amplified. And this is amplified in settings that are indoor, where people spend prolonged periods of time together, and particularly in situations where there is poor ventilation. And we are continually learning about transmission among children. But what is important for WHO is that we translate this evidence into knowledge. We turn this know-how into how-to. We need to turn evidence into policy, turn evidence into what drives policy. And we have a system, a feedback loop that's in place, looking at evidence, looking at the science, and leveraging the world's expertise through our expert networks, our collaborating center, our strategic advisory groups, having consultations through virtual consultations now, through our R&D blueprint for epidemics, and through studies that are being carried out, our solidarity studies and our unity studies on the ground. We leverage that evidence and expertise into authoritative, accessible guidance, which is multidisciplinary, it's multilingual, it's multi-agency, and it's adapted for different contexts. We look at the implementation of this through many different types of platforms, using digital transformation of knowledge into learning using innovative training platforms like OpenWHO, which existed before this pandemic, but was leveraged in this pandemic to rapidly get out training materials in a large number of different languages to make it accessible to people with high bandwidth and low bandwidth. We work through our 150 plus country offices and regional offices to make sure that we tailor the operational and the technical support as needed. And we are leveraging all of the different multi-agency partners that we have throughout the UN, through our GORN platforms, our emergency medical teams, and through the TechNA network, which is a really interesting network leveraging engineering and architecture to make sure that we have the right facilities that are caring for patients. Then we make sure that we monitor and we evaluate, we learn from this. We have KPI-driven monitor and evaluation. We look at case studies. We look at operational research. infodemic monitoring and engagement, intra-action reviews to make sure that we course correct and that we look at the feedback from countries, which again feeds back into the evidence. Our evidence is rapidly and constantly reevaluated and updated as evidence grows and as experience grows. Some of the key achievements in this response has been the delivery of materials. There's been almost 300 million items of personal protective equipment, of diagnostic and medical supplies shipped around the world. One of our most incredible achievements, I think, is the ability for us to have developed rapidly PCR tests. From the availability of the full genome sequence on the 10th and 11th of January 2020, WHO and partners were able to develop a PCR assay. And this was first developed by Charity University and published on the WHO website on the 13th of January, less than 2 weeks after WHO learned of the cluster of pneumonia in Wuhan, China. And from then, we worked with companies to develop PCR kits, and we were shipping those around the world by February 2020, a year ago today. And since then, we have been working to improve the global supply chain, to ensure that we get PPE to our frontline workers around the world, those who most need it. Now, the global supply chain has improved over time, but it is still not fixed. We still are lacking the ability to get PPE, gloves, gowns, goggles, masks, respirators to frontline workers who need that. And that is something we are continuing to look at. We are looking at innovation in different ways that we can get PPE developed to make sure that we have PPE that fit women, because we know most frontline workers are actually women, but PPE is actually developed for men. So there's a lot of innovation in this space. But we do have some challenges ahead. The virus variants that have been recently detected in the United Kingdom, in South Africa, and Brazil show us that this virus is evolving. This is natural. Viruses constantly change through mutation, and SARS-CoV-2 is no different. This is expected. Many of these mutations are neutral, but some are in fact detrimental to the virus, but a small number of them make the virus more fit. And this is what we are actually seeing in real time, that these viruses are evolving. The SARS-CoV-2 virus is evolving. And we need to make sure that we have good surveillance in place that can rapidly detect these mutations so we can quickly detect them. And by doing that, we need increasing diagnostic and sequencing capacities globally. We need the timely sharing of sequence data internationally, and we need to improve bioinformatics so that we analyze these sequences along with other epidemiologic and clinical data. And that requires close collaboration so that we can study the potential impacts on transmission, on disease presentation and severity, and on the potential impact on diagnostics, available and future diagnostics, therapeutics, and vaccines. And this really requires coordination of many, many different partners across WHO at 3 levels of our organization and with many partners around the world. WHO is working to establish a risk monitoring framework to evaluate SARS-CoV-2 variants of concern. There are many components of this framework that are required for its success, and there are many principles that outline, that are listed here that show that are needed for this to work. I have this illustrated on the slide here, showing the different components. There are many different inputs that you'll see on the left, from member states, from technical networks, from partners, linking in much information related to enhanced surveillance, virologic surveillance, epi-surveillance, genomic surveillance, making sure that we have good data sharing and analysis that are taking place in real time so that we can understand the phylogenetics, we can understand any trends or changes in trends in terms of transmission or severity. WHO established a virus evolution working group in June of last year to make sure that we had a mechanism in place to outline the laboratory studies that are necessary and to coordinate those lab studies across labs around the world so that not the same labs the different labs are studying the same mutations. We need to spread that work around so that we can evaluate these over time. We need to link with our R&D colleagues to make sure we have animal model work coordinated and that we link the research for the diagnostics, the therapeutics, and the vaccines. Because we need to understand if any of these variants of interest are actually variants of concern. All of this information and this coordinated information, and WHO is providing a key role in coordinating all of this work, It will feed into WHO's rapid risk assessments, as well as any revisions needed for guidance in terms of our public health and social measures, as well as any changes that will be required for diagnostics, therapeutics, and vaccines. We have seen some of the virus variants show some reduced neutralization, and so that may have an impact in the future on our countermeasures. But so far, the variants that are circulating, we do see that public health and social measures are driving down transmission, and we do see that the vaccines are still working against severe disease and death. Looking ahead, we really know much more than we did a year ago. We have developed operational and scientific solutions, but we have not yet applied this knowledge and these solutions around the world comprehensively and evenly. We need to stay the course. The epidemiologic situation is dynamic and it's uneven, and this is further complicated by the variants that I just mentioned. But many countries are showing us that they can continue to suppress transmission, including in countries where these variants are circulating. The healthcare systems and workers have saved countless lives, but they are under extreme pressure in many countries in terms of capacity, in terms of workforce and supplies. Our surveillance systems globally are finding it hard to cope with the high force of infection. Case cluster investigation, contact tracing, and supported quarantine of contacts remain underpowered in large parts of the world. And this is something we really need to build all over the world. So that as we talk about building back better, part of this is to ensure that we have surveillance systems and a workforce in place that can fight not only COVID-19, but the next infectious disease that will undoubtedly plague us. We need to make sure that we support communities so that they can continue to maintain public health and social measures, because they are suffering from a loss of social cohesion, education, income, and security. And all of us are really, really feeling that. We need to continue to fight the infodemic and make sure that we fight misinformation and disinformation, because this continues to undermine the application of evidence-based response and our guidance and individual level behaviors that we need people to adhere to. Science has delivered on solutions, and these are being scaled up, but we need to make sure that we have a strong mechanism and equitable delivery, and you've seen that through the COVAX facility. We need to make sure that we provide vaccines to those most at risk in all countries, as opposed to vaccinating everyone in just a few countries. And in 2020, we must redouble our efforts to suppress transmission, to protect the vulnerable, and save lives in a comprehensive, in a coordinated, and in an equitable way. Major areas of critical focus going forward: we need global collective action to end this pandemic. We need strong national leadership implemented from all of government and all of society plans, and that needs to be coordinated not just at the global level, but also at regional levels, and applying these tools evenly and consistently so that we drive transmission down. We need to reduce and control transmission and prevent amplification events, especially in areas where we know transmission can be amplified. In these type of outbreak settings, there are certain occupations, there are certain settings, especially in closed indoor spaces where there is poor ventilation. We need to provide clear, consistent, and open communication, acknowledging our humility when we don't know everything and communicating uncertainty in these very, very difficult times. We need to save lives, as many lives as we can, by protecting vulnerable groups and ensuring we have good, rapid, high-quality clinical care. This is critical. We know so much more now about treating patients and getting patients into the clinical care pathway, that we can save lives with early treatment, with oxygen, with dexamethasone for those who are severe and critical. And we need to continue to accelerate the development and access of COVID diagnostics, therapeutics, and vaccines through global collaboration and fair allocation. And you know you've seen this through our Act A and our COVAX facilities. This is just a schematic of outlining what I just mentioned here, making sure that we reduce exposures, infections, mortality, and transmission. And we do this by empowering individuals and communities collectively for action. It's one thing to say what to do, but we need to constantly engage with communities and have an open, honest dialogue about how we work together and how these interventions are implemented at local level. We know that informed, engaged, and enabled communities are what drives actions, and we really strive to make sure that we do that in a consistent in a continuous way throughout this pandemic. These are incredibly challenging times, and we are all working on this together to get through this together. I thank you so much for the opportunity to speak with you today, and I stay safe. Make sure that you follow all of the measures to keep you and your loved ones safe, and we will definitely get through this together. Thank you.
Thank you very much, Dr. Maria. We now move on to the next session. May I now invite Dr. Balram Bhargava, Secretary, Department of Health and Family Welfare and Director General of Indian Council of Medical Research. He is the Professor of Cardiology at All India Institute of Medical Sciences, New Delhi, and serves as the Executive Director for Stanford India Biodesign Center School of International Biodesign. Established by Professor Bhargava, the School of International Biodesign at AIIMS is developing low-cost medical advices, and he is leading the ICMR in the fight against COVID-19 in India. Over to you, Dr. Balram Bhargava.
Thank you so much, Honorable Minister, Shailja Teacher, and the other members of the Kerala Health Making SDG a Reality, and this the COVID pandemic response resilience preparedness webinar. Now, I will share some slides before, so I hope you can see those slides. Yeah. How do we make it? Full screen. Okay. Yeah. I hope the slides are visible now.
Till Dr. Balram Bhargava joins us.
I have joined. Can you see my slides?
Yes. Please stay, sir.
Yeah.
Yeah.
Can you see my slides?
We can hear you, but
Yeah.
please proceed, sir.
Can you see the slides?
Yes, yes, sir.
Okay. So, so we will talk about the India's fight against COVID-19. We've heard the WHO, and let us see what we have to talk from India, and why we have seen this COVID pandemic, particularly this century, has witnessed several exotic and viral infections. Again, more frequently, we've witnessed SARS, MERS, Ebola, yellow fever, Zika, and Kerala has been the brunt of Nipah twice. Possible reasons are the change in environment and ecology, rapid urbanization, and extreme connectivity. People are traveling too much of movement, and neglected public health and inadequate spending on public health. So these are the possible reasons for this pandemic. We will see more of this, and we have to work more efficiently. And Kerala has always been an example for us in terms of the Nipah. We have seen them work so well in 2018, 2019, and so we will have to work more closely. In terms of India's COVID response, India being the largest democracy with respect to people's voices to calibrate its interventions has been a success story because of the fact that India was serious right from the beginning, where it was a whole of government approach with a calibrated, proactive, preemptive, and a graded response. It was science-driven with best practices and evidence-based, and we had a strong leadership with excellent communications with all the states and all the stakeholders in the game that helped tremendously to keep the country together in every which way and guide the country tremendously from the central leadership. We adopted the 5T strategy, that is the test, track, trace, treat, and use of technology. And we, most importantly, which has been alluded to by the Honorable Minister as well, is that we resisted the concept of herd immunity. We still do not play around with herd immunity. Many countries fell flat on the face when they said herd immunity was the right way. We have examples of United Kingdom, Sweden, parts of United States who embraced herd immunity and had problems. So we have never resisted the concept of herd immunity, and we had to rapidly set up our testing facilities. As we know that on the 30th of January, we had the first case from Wuhan, the medical student who traveled from Wuhan to Hong Kong to Calcutta to Bangalore and then to Cochin was detected to have the virus on the 30th of January by the ICMR, National Institute of Virology in Pune. And subsequently, we set up the various laboratories gradually, scaling them up to 2,376 today, out of which 1,217 are government and 1,159 are private laboratories. We took about 10 months to do the first 10 crore tests, and the second crore tests were done in 3 months, and we have now completed more than 20.4 crore tests conducted across the country. Our strategy was very calibrated because in January, we had only one lab testing. And at that point in time, we were testing only travelers in February. Gradually in March, some more labs were tested. We had paucity of kits, and much of the kits were being imported, and some of them were supplied by WHO to us. And we had then scaled up our testing to SARI patients, healthcare workers, and the contacts. And in April, we were able to repurpose the molecular test, the TrueNat, which we have been using for tuberculosis so effectively and has also received WHO pre-qualification, which we have repurposed for in the month of April, and I'll talk more about that. Then we scaled up a little bit more, and in June, we again were innovative and used the rapid antigen tests for the first time in the world, and that rapid antigen tests got WHO pre-qualification in the September of 2020. And in September, we had on-demand testing available in our country with a large number of immunocompromised, pregnant women, high-risk population, atypical, hospitalized patients, pool testing. All these were calibrated depending on the availability of the kits, depending on the availability of the laboratories, and the availability of trained personnel with quality assurance. So we upscaled our testing with a vision to have a laboratory in every district, and labs were set up in difficult terrains in Andaman Nicobars, Leh Ladakh, Jammu and Kashmir, and Sikkim and Lakshadweep. And we also were able to set up, today we have RT-PCR testing laboratories in 659 out of the 741 districts, and all districts have rapid antigen testing facilities. Initially, the phase 1 was larger cities and urban areas where we used the RT-PCR testing laboratories, and they were scaled up. And how they were scaled up, I'll come to that. In the district level, we deployed the TrueNat, CBNat, and the Abbott machines, and in the field level, we used the antigen testing. Now, the point of care TrueNat machine, which is a laboratory in a suitcase, weighs only 3 kilograms, and we deployed it from the month of April, and today we have 2,530 TrueLab workstations which are operational, and this has been appreciated in the Lancet as well, because the British started the DNA nudge in September, 6 months later than when we had started this system. We had also repurposed it for Nipah and also for leptospirosis, and so we knew how to utilize this testing facility. Although the number of tests done on this machine are less, but it can be taken to the field. It is portable. It has does not require such biosafety measures because the virus can be lysed in it. For increasing the access to diagnosis, we had 14 mentor institutions which were across the country, which were hand-holding and approving various laboratories in private and government medical colleges. We had 16 depots which were established for efficient distribution of supplies. This was during the lockdown. And at that point in time, ICMR, the Department of Health Research, was working 24/7, 7 days a week, with people working till 2 a.m. in the morning, and ensuring that operational lifeline Udan with Indian Air Force, Indian Post, Indian Railways was responsible with helicopter flights going in the middle of the night to different parts and remote areas, supplying the kits to different parts of the country. We did a gazette notification to make it mandatory for all MCI registration of medical colleges on the 3rd of June that they have to set up a RT-PCR laboratory. And today we have 526 out of 536 medical colleges which have RT-PCR laboratories, and that they are an asset now for other molecular testing to be done in the future, whether it be for tuberculosis and other eliminable diseases. We had high throughput laboratories set up in different parts of the countries to be calibrated and distributed in the north, south, east, and west of the country. And we also set up high throughput multiple RT-PCR laboratories, a dozen of them in one facility, which can test up to 10,000 tests per day. We had the third peak of the epidemic in New Delhi, and we had to upscale the RT-PCR testing tremendously to up to 75,000 tests. And we had the mobile RT-PCR test laboratories. 10 labs were deployed in different remote areas of Delhi, and they were testing up to 2,000 samples a day. And they were mobile. They can be moved anywhere with 2 to 3 RT-PCR machines in each one of them. In February of last year is more emotional than anything else, that we were able to, we had about 6,000 of our pilgrims stranded in Iran who were visiting the holy sites there. And we, ICMR and IV sent 6 scientists by emergency flight to Tehran with all the lab equipment. And we set up a laboratory at the Embassy of India in Tehran, and 2,028 samples from 5 cities with very high 15% positivity was tested, and special flights were arranged by Indian Air Force and Iranian Airlines to repatriate of these Indians. Similar facilities for testing and collection of samples was done in Italy during the months of February and March before lockdown happened in India. For inventory, we had a demand forecasting, and this was to enable information on stock out of status and lab requirements and suggestive dispatch quantities. And we had 20 ICMR depots established for seamless distribution of testing commodities across the country. And we had the single source of truth for all the data, and the data entry portal of ICMR was commissioned, and that monitored disease trends, policy making, resource planning, and also clinical decision making. And this was activated very, very soon, and has been, with the help of NIC, we have been able to keep it as a robust system for data. For capacity matching and capacity assessment for procurements, we had tendering of the Government of India. We had Government of India GEM portal used for procurement, and we had robust projection and testing commodities and what type of reagents, machines, mix, manpower, labs, operating hours, 3 shifts, 2 shifts. All this was assessed, and we had a self-reliance in diagnostics and vaccines. We developed the first indigenous human ELISA kit as we had isolated the virus in the month of March, and therefore we were able to develop the ELISA kit within a matter of weeks, which was used for the first serosurvey for testing, and we have validated 1,184 diagnostic commodities, and 419 are indigenous, and they are available, and they were responsible for India becoming self-sufficient. In the month of March, April, we were begging for diagnostic kits from many parts of the world and the WHO, and immediately our industries and our innovators rose up to the occasion and developed various VTM kits, RNA extractions, rapid antibody kits, and RT-PCR kits. Quality control and quality assurance for RT-PCR, we had 38 labs, and for RAT testing, we had another 28 labs for rapid antigen testing. All these kits are now have since the month of May, June, been available on the government e-market, whether it be viral RNA extraction kits, antibody kits, or the antigen kits, or the master mix probes. They were so decentralized procurement for augmenting for the states to procurement of their own. And since August, the states have been procuring on their own, except some central laboratories are being supplied by the center. The cost of the RT-PCR kits is fascinating, because it's a fascinating story, because initially the cost was 1,727 rupees in the month of March, which included the RT-PCR, RNA extract, and the VTM kit. And this has come down to 135 rupees as we speak. And we, because of this coming down of the cost, the international kits also reduced their cost, and we are exporting them to different parts of the world. And 1,048 lakh VTMs have been exported, 949 lakh RNA extraction kits, and 494 lakh RNA RT-PCR kits have been exported. We isolated the virus. We're the 5th country in the world to isolate the virus on the 9th of March 2020. This aided in the development of the ELISA kit, the monoclonals, the laboratory assess, the antiviral screenings, and most importantly, the vaccine development. We were the first country in the world to isolate and culture the SARS-CoV-2 UK variant, which was first reported in the world and published in the Journal of Travel Medicine. We conducted 3 countrywide national serosurveys across 70 districts, 21 states, 24,000 individuals, and in the 3rd serosurvey, we also include 7,000 healthcare workers, and these have been published in the Lancet Global Health. And the first NCS was 0.7% and then 7.1%, and the 3rd national serosurvey shows 21.5% seroprevalence, with 25% in the healthcare workers and about 32% in urban slums in large cities, where we have reached 32%. Sewage serosurveillance was started. We standardized the method, and this has been implemented at 20 sites in Mumbai, and phased expansion with the WHO polio surveillance is happening for sewage surveillance. In terms of clinical studies, as mentioned by the earlier speaker, the WHO Solidarity Trial, the 10% of the cases for the WHO Solidarity Trial were from India, and we did a study on HCQ prophylaxis. The largest trial in convalescent plasma in the world was the PLACID trial, which was published in the British Medical Journal, conducted by ICMR across 40 medical colleges in the country and more than 450 subjects. We developed the monoclonal antibodies, and we have screened more than 100 antiviral products and have 3 issues of the Indian Journal of Medical Research, dedicated volumes on COVID, and the 4th volume is also in compilation. In terms of the COVID vaccine development, Bharat Biotech, we supplied them with the virus, we characterized the vaccine strain, we conducted preclinical studies in hamsters and monkeys, and we provided technical and lab support for phase 1 and 2 and financial support for phase 3 as well. We did the phase 2b/3 trial, financial support and the technical support for Serum Institute, and now we are providing support for the phase 2 and 3 for the Covovax, the Novavax, and also for Zydus Cadila. We did the preclinical studies on monkeys at ICMR and IV Pune, and now more the biological events and Reliance Industries have approached us for their vaccine candidates to be tested out at ICMR and IV Pune. In terms of Covaxin, we've published humongous preclinical data for Covaxin on mouse, rabbits, and rats in iScience, which is a Cell publication, monkeys in Nature Communication, hamsters in iScience, which is again a Cell communication, and a comparative efficacy in the monkeys in the Indian Journal of Medical Research. The clinical trials have been published in the Lancet. Phase 1 and phase 2 is is already accepted. We've got the proof and should be out anytime next week. The phase 3 has been completed. The samples have both the 25,800 volunteers have been given both the doses of vaccination, and their interim analysis should be out in another 2 to 3 weeks. We have done the Covaxin neutralization for the UK strain, and that has already been accepted for publication in Journal of Travel Medicine. In terms of the SARS COVID Genomic Consortia, the Ministry of Health and the Ministry of Science and Technology, along with 10 institutes, have set up the Indian National Science SARS-CoV Genomic Consortium with the sentinel surveillance, and to determine the circulating strain and see if there is any high mortality or super spreader events. We were able to isolate the UK strain, and 187 UK variants have been found, and we have been able to culture the UK strain, and this culture paper has been published, and we found the neutralization potential with the UK variants matches with other heterologous virus strains in India with the Covaxin vaccination that we have developed. The South Africa variant emerged independently in South Africa, and we had 4 travelers with this strain detected only in January and February actually, and we are trying to isolate the virus so that we could look at the efficacy of the vaccine against the South African variant. The Brazilian variant, the last week of January and early February was the one traveler we were able to isolate, and we were lucky enough to be able to culture this Brazilian variant, and the vaccine efficacy against this variant is being tested, and the vaccine specifically for this variant is also being developed in case the current vaccine is not successful. We have over the past few months developed the national biorepositories for all the COVID-19 samples, and also we developed the clinical registry. Although this clinical registry was slightly late, but it started in the month of July, August, and this is more than 40 hospitals across the country where we are collecting data of patients who are admitted prospectively and what their treatment is being given, how they are faring after their discharge, and for telephonic follow-up. And we have more than 10,000 from the COVID National Registry with complete data, which we shall be publishing very soon. We established the National Task Force on COVID-19 in the very early during the epidemic in the month of March 2020 for advising us on calibration of testing, for developing advisories regarding discharge, to basically advise the government on lockdown and containment strategy, to provide oversight on ongoing research, newer and repurposed treatment options, and to develop clinical management protocols. I thank you. I will stop here because I think I have overshot my time, and I thank you for your attention, as attention is the rarest and the purest form of generosity. Thank you so much for your kind attention.
Thank you, Dr. Balram Bhargava, for those insights into India's fight against COVID-19. Let's move on to the next session. May I now invite Dr. Yeah, we have with us our Honorable Minister, the Director of Health Service, and the Director of Medical Education. We have listened to the global and national response. Before we move on to the next session, let's wind up these initial 2 ones. May I now invite Dr. Ramla Devi, Director of Medical Education, to propose the vote of thanks for this session, to conclude this session.
Thank you, Indu. Respected our Honorable Health Minister, Shailaja Teacher, respected dignitaries in the dais and all the participants. Since we are running out of time, I quickly go through my vote of thanks. First of all, I extend my sincere thanks to our Honorable Health Minister for the excellent leadership and advices for giving to us. On behalf of Kerala Health team, I extend your sincere thanks to you, Madam. And next, our thanks goes to our Principal Secretary, Rajan Khobakade, sir, for their leadership. I extend you sincere thanks to you, sir. Then my sincere thanks goes to our young IAS team, Director and Health Sir, Sri Raman, and our e-health team that is led by Shafirullah sir for their excellent support and guidance. And also I share some sincere thanks to our Director of Health Services, Sarita Madam, for their support. And also on behalf of the Kerala Health team, I extend my sincere thanks to all the participants, all the speakers in this session, and wish you all the very best for the participants and all the faculties from various places. With these few words, I conclude here. Wish you all the very best. Thank you.
We are moving on to the next session, which is on Kerala's response to COVID-19. May now invite the leader of Kerala's health team, Dr. Rajan Kubragade, our Principal Secretary, Health and Family Welfare, to lead the presentations. Over to you, sir.
Good evening, everybody. Along with me, Dr. Dilip is here, so I will request Dr. Dilip to join me here on the dais. The way we are going to present today, the Kerala story is in a little bit different way, because along with me, 5 of my colleagues are there. Now, they are the representative of all the colleagues who have been working at the grassroots at various level, working at the district level, working at the state level. So I'll structure the session in this way. The broad policy framework our Honorable Minister has already covered in her presidential talk, and therefore I will not take any time regarding that. Along with me, Dr. Arvind, who is spearheading the infectious disease department in Medical College Trivandrum. Then Dr. Sandhya, who is a district surveillance officer, Kollam. Dr. Sakina, who is a DMO, Malappuram district. Dr. Raman, who is a DPM from Kasaragod district. And for any department, the supply chain management is a backbone. So for health department, the supply chain management is managed by Kerala Medical Service Corporation General Manager Dr. Dilip. And with these 5 of my colleagues, we will be taking you through what Kerala has been doing. So now I call upon Dr. Sakina to inform all of us the strategies what we have put forward, how those strategies have been implemented at the grassroots level. Over to you, Dr. Sakina. Dr. Sakina may start the video.
Thank you, sir. There is some problem with my video, sir. Good evening, sir. Good evening, all.
Please go ahead.
I am presenting district planning and management during COVID pandemic. And Kerala was the first state affected by COVID-19 pandemic in India. And the state successfully flattened the curve of pandemic using the components trace, quarantine, test, isolate, and treat, and the awareness campaign break the chain. Extra attention to food, shelter, medicine, access for vulnerable groups like migrant laborers and elderly were given. Withdrawal of stringent lockdown and non-adherence of people to physical distancing led to rapid increase in cases. Case fatality rate remained low. Moreover, the mortality concentrated among elderly comorbid patients. Maintaining an optimum balance between tackling COVID-19 and non-COVID essential services, the state is leading. When the international alert of a new infection came on 3rd week of January 2020, the state had a unique response with the setting up of district COVID control cell in all districts before January 30th when the first case reported. And then anticipatory COVID isolation units established, and daily situational review made the information flow faster. Initiated airport surveillance in all districts with airports and deployed medical teams, and started quarantine and screening of travelers from China. Line list of travelers maintained. Training and alert to health team done. Later, dedicated surveillance unit to do daily follow-up of international travelers from high-risk countries started, and field surveillance was through rapid response team constituted from local community. Community health volunteers, including our community health volunteer ASHAs and local volunteers under the supervision of local health staff. Existing Arogya Jagrita Samiti helped to constitute RRT without delay. My colleague Dr. Sandhya will be explaining more about surveillance and testing. Contact tracing cells were formed. A multidisciplinary team of medical and non-medical students and volunteers from the district helped to have good rapport with the public. and cases could be established. Isolation facility expanded further with additional beds and mobile testing units designed and started functioning. New testing centers started in strategical location in the district in major government hospitals, and the system was ready when the first case got reported in this stage. The district had to manage a disaster during the pandemic. Even though there was a possibility of a large outbreak, we could contain that. On 7th August 2020, following a crash of plane with 184 passengers and 6 crew members, there were 19 deaths. More than 800 local people were involved in rescue operations, and the risk for COVID transmission, both from travelers and evolving geographical coastal conductivity block were there. A dedicated district air crash rescue control cell phone number was started, and campaign on self-reporting of COVID status by rescuers were launched. Reporting through local health institutions also was initiated. COVID-19 testing of all traced rescuers was performed after 6 days of exposure. 1,144 tests were performed, including rescue officials, that's CISF, airport staff, fire and safety, police, etc., and local people who took part in the operation. All were advised to undergo 14 days quarantine. Key strategies. Decentralized planning of human resources and infrastructure were one of the main component, and community participation and intersectoral coverage with LSTD involvement, that is a rapid response team, and COVID first line treatment management committee with the incorporation of LSTD and community level volunteers, and community kitchen through Kudumbashri were the very good examples. Strengthening of public infrastructure as an opportunity to strengthen the public facility, and public-private participation and training and capacity building of critical care management. We utilized the private sector also. Continuum of COVID care through CFLTC and second line COVID treatment centers and COVID hospitals, and iterative IEC on break the chain campaign. Walk-in testing centers were introduced according to the need, and now we have 289 centers. District program management and supporting units under the DDMA, under the chairmanship of district collector, and it is doing the transportation and referral of serious patients. And we have done and now doing all the management under the USG framework, ensuring population and service coverage with risk protection. Thank you.
Thank you, Dr. Sakina. In fact, you have given a good overview of what management practices we are putting into place at the district level. And in all 14 districts, in the similar way, we are going forward. Now I will request our district surveillance officer, Dr. Sandhya, to tell us something about how we have drilled down and how we are doing the surveillance overarchingly in the state, and also by taking some example from Kollam district. Over to you, Dr. Sandhya.
Thank you, sir. Very good evening, sir. I will be speaking regarding the surveillance on COVID-19 pandemic in Kerala. So mostly with the reporting of cases in Wuhan city in China, as well as like in the other countries and across the world, we have stepped up our surveillance in Kerala state. So because of we quarantined all the people who returned from Wuhan, as well as from the other countries where ongoing transmission of COVID is happening, and we did the symptom surveillance. So we were able to pick the first case on January 30th, 2020. So at first we sent the sample to airlifted to NIV Pune. From thereafter, we were sending the sample to, thereafter we have started our lab in Kerala itself, NIV Alapi, and then soon ICMR approved most 7 government labs as well as some private labs. As of now, we are having 2,245 labs in the all over in the state doing the testing facility. So like we are doing the RT-PCR, TrueNat, CBNat, and antigen testing across the state. We have walk-in facility for testing all those cases who can go to the private labs and just do the testing, and the results will be uploaded in the portal. So
Dr. Sandhya, in fact, I will request you can keep your mic piece properly so that you will be more with a clarity audible to all of us. Thank you.
Am I audible now, sir?
Please go ahead.
Okay, sir. So like coming to the part of surveillance, like what we are doing is like the routine testing facility is going on in our lab. All the 100% positive case contacts are being tested. Then there is the sentinel surveillance facility, the zero surveillance facility, as well as the cluster containment strategy, and also the ILA surveillance that is happening in our uh, in the all across the state. In the sentinel surveillance, what we do is all the most highly exposed and the vulnerable categories are being tested. Usually that include the healthcare workers in the non-COVID settings, then the police, migrants, guest workers, then the workers in the organized as unorganized sector. Along with that, epidemiological samples are also being collected. In this viewpoint, I would like to share one success story of Kollam district, where in the initial phase during the sentinel surveillance part, we detected one of the healthcare worker, a symptomatic case as positive, and we took a detailed contact history and route map of her for the past 14 days regarding her travel history and her contact cases. All the contacts were traces, and we got 8 cases, and we tested all them, made that area into a containment zone, did ILI surveillance, just testing of all the vulnerable people, and we were able to contain the cases at that point of time. Then we do have, as part of the surveillance, what we do is 100% ILI testing. Then we had the international and interstate travelers being testing. Right now, the special attention is given to the UK returnees also. Then we are doing the testing of the, sorry. Then we are doing the, sorry, the 100% testing we are being done for all these category of people. Coming to some of the success stories I would like to tell is that in Kollam, we have these close cluster groups in Kollam. That is for 15 houses, we will have one person who will be identified, who will be a retired government servant who is well approved by the families, and they will form a social group, and the people who are under quarantine will be kept in that area, or their needs will be addressed in that area. Then they will provide the medicines if in case of need. And in this cluster containment group, there will be one nodal officer who will be a local self-government secretary, who will who will be in turn supervised by a tahsildar and in turn by the district collector, who is in charge of the district disaster management authority. Because of this close cluster group, we were able to prevent cases occurring in the market areas as well as in the coastal areas. This is very effectively running in Kollam, and I would like to share one success story of Kollam, where Alapad, one person spread lot of cases, and effective contact tracing was done, and all the contacts were tested, and all the positive cases were identified, and we were able to contain them. So another intervention that is done across the state is the workplace intervention, where migrant workers, MNREGs, brick clean factory workers, cashew factory workers, all were tested during this period, and if there is any positive cases, then the cluster containment activity will be done in that area. Along with that, we have the step kiosk facility along with the public-private partnership, and so that is established at the railway station as well as the bus stand, and in areas where more population movement is being done, and we can do the testing facility accordingly. Similarly, like in destitute homes, old age homes, we have strengthened the testing facility, and we are even doing random sampling from schools and destitute homes, but every 2 monthly we are doing the testing arrangements there. So with good surveillance, 100% contact tracing, 100% testing, then by active surveillance, then 100% clusters containment activities, and 100% ILI testing, we are able to see not only the tip of iceberg, but also the whole of iceberg, and we are in the right path of containing the disease. And all the positive cases will be rightly followed up, and based on the categories, they will be shifted to the health facilities, about which Dr. Raman will be speaking in the next section. Thank you.
Thank you, Dr. Sandhya. In fact, our apologies, I think because of the network, the clarity was lacking in some of the places. What we are trying to do in surveillance is at this point of time is at the grassroots level, massive awareness campaign is done. Kerala's strength of literacy and the social capital is giving us a benefit. So very pinpointedly, those people who are having symptoms, they are accessing help, and we are going ahead with the testing. That is what our honorable minister has also told, the number of tests what we do in the state. Second point in the surveillance, by doing the testing and the results, we immediately identify whether there are any cluster formation at the district level. And once we identify in the cluster 100% elderly people, pregnant mothers, child who is a little bit malnourished, and any person who is having a morbidity, all of them 100% tested. So our strategy is to understand whether there are new foci of infection, break the chain, and take them to the treatment track. So now we will go ahead, and I will request Dr. Raman to tell us about the operational issues and other management, what we do at the district. Over to you, Dr. Raman.
Thank you, sir. Good evening, everyone. We all know that the knowledge about COVID is day by day rapidly evolving, and there were various challenges faced by the state during the initial phase of the pandemic. Today, I will be briefly discussing about the two major challenges faced by every district in the state. That is, first, how to arrange the facilities to manage the SARS-CoV-2 suspects and cases, and second one is how to manage the human resources we were having. Next slide, please. Yeah. From the beginning of the pandemic itself, when expatriates were coming to Kerala in large numbers, the state of Kerala has prepared well in advance for receiving these expatriates. In the initial phase, there were some hiccups regarding the management and transportation strategies. But with meticulous planning and with great intersectoral convergence with health department, the revenue department, the local self-governments, and the police and the transportation authorities, and with the introduction of the COVID Jagrata application, we were able to curb these difficulties in the initial phases. So I would like to start. Kerala is probably the one and the only state in the country to have the 5-tier system of management of COVID patients, suspects and patients. We have the COVID care centers or Corona care centers, the COVID first-line treatment centers, the COVID second-line treatment centers, the COVID hospitals, and the domiciliary care treatment centers. In the COVID care centers, which were constituted at the local self-government level, for managing the expertise, because we initially managed the expertise at the facility itself, because that has greatly helped us help us in preventing household transmission rates of COVID virus from the expertise. Then, because our system was always dynamically evolving from the beginning of the pandemic to right now where we are, our system and management strategies were continuously evolving in a dynamic manner. So after the Corona care centers, we have started the COVID first-line treatment centers for managing the mild or asymptomatic cases. Then we have the COVID second-line treatment centers for managing the mild to moderate cases, which has been started. The Corona first-line treatment centers and the Corona second-line treatment centers has been started as a hub and spoke model, with the COVID hospital at the hub and the first and second treatment centers at the spoke, as the spokes. Then in each district, we have converted some district level or medical college level hospital into a dedicated COVID hospital. So far, we have 29 dedicated COVID hospitals in the government sector and a lot of the private sector hospitals also. So what we have done is, we have converted the district level or the medical college hospitals into COVID hospital without much disrupting the routine functioning, routine caregiving of the institutions by decentralizing the entire process that has been happening at the institute at the main hospital, and also by public-private partnership and the use of telemedicine technologies, and also delivering the medicines and essential goods at the household of the chronic patients. Then in the late stages of the pandemic, we have started the home isolation. So then, during that period, when some people were not having the adequate facilities for home isolation, especially in the tribal areas or in the urban slums or in the coastal areas, we have started the domiciliary care centers where they will be provided free treatment and care. Then just look at the slide. This slide shows the average number of beds we have what's accumulated over the year. Over a year, we have almost 2 lakhs beds ready in the first-line treatment centers and the second-line treatment centers and the domiciliary care centers. These the importance of these beds are that these are in addition to the regular health system beds that are available, so that we were able to manage the high load of cases. And in this way, the meticulous planning and the load balancing at the hospitals, both at the private sector and the public sector hospitals, helped during the pandemic, guarded our health system from collapse. Next slide, please. The second point I want to impress upon is the management of human resources. Our human resource management strategy was focused on 4 points. First one is human resource pooling, the rapid recruitment of the staffs, then the state's prestigious COVID brigade program, and providing psychological support to the staffs who were working in the crisis, the frontline warriors. So by HR pooling, we have pooled the resources from wherever our resources, from our own department, Allied department, Ayush department, and some other departments that we have pooled for testing, quarantine and surveillance and isolation and quarantine activities. Then the government has rapidly recruited, even the government has created more than 1,000 posts and rapidly posted people in those posts on a war food basis and filled all the existing vacancies Along with that, the government has posted more than around more than 14,000 COVID brigades of various categories, more than 85 categories, to support the low resource settings. Then, to maintain the psychological support of all these staffs who were working in the front line of COVID management, we have added tele-counseling services with psychologists and psychiatrists to the staffs for giving them psychological support. And even we have arranged celebrity chats with the few of the film stars also to provide them some psychological relief. Next slide, please. So to sum up, Kerala was able to bring together its past experiences, improved healthcare facilities, and decentralized governance for successfully surmounting the challenges associated with the pandemic. The grassroots level health system, coordinated at the district level under the guidance of the state with support from the local self-government and police departments, were the key for success management of the pandemic in the state. Thank you.
Thank you, Dr. Raman. In fact, you have told us very nicely, if we take one patient, that patient will be needing some place to recuperate. Now that place will be home or the domiciliary care center or first line treatment center or second line treatment center or COVID hospital. So at no point of time, in fact, the health infrastructure gets overwhelmed. If instead of one patient, if we are going to get 10,000 patients in a day, still we have equipped all the infrastructure in all the district in such a way that even if there is a massive surge, all the management professionals at the district level will be tackling those problems very effectively. Now I will request Dr. Dilip to briefly tell us that whole operation becomes successful provided if we ensure the supply chain management. Over to you, Dr. Dilip.
Good evening. I am representing Kerala Medical Services Corporation, the central procurement agency for the state, who is the backbone for the whole COVID pandemic situation control for the state. We had an emergency plan of action based on the rich experiences gathered out of 2 Nipah epidemics as well as devastating Kerala floods 2018. From the past experience, we had maintained good institutional as well as warehouse buffer stock, out of which we could manage initial surge of cases. These are the challenges we have faced during the initial epidemic period as well as whole pandemicity. The second aspect covers how Kerala Medical Services Corporation, under the guidance of state government, could cover the issues as well as crisis. Let me invite your attention to the challenges. Global supply chain disruption, it is one of the global phenomenon where there is huge gap in demand and supply. The lockdown situation globally as well as pan-India has created a lot of hurdles for the procurement agency for mobilizing good quality stuff, which is the backbone for the front-end health workers to fight against the COVID. Then there were HR constraints, there were space constraints, there were issues regarding the prioritized distribution to the needy institutions. We could succeed all the crises, whatever I have detailed in the limited verse, by exploring the possibility of supplier collaboration, pre-procurement sample evaluation by experts, intelligent workflow for supply chain with dedicated crew. I'm not going for all the details. The things are being detailed in the slide. See, these are the few landmarks regarding the procurement per se. As detailed by my previous speakers, the state has gone through increasing the laboratory testing. State has gone through improving the critical care amenities. State has gone through the setting up of infrastructure along with equipping the health facilities by providing qualitative stuff for personal protective gears for front-end health workers. I'm not detailing all the figures. I think the slides will speak. This is in nutshell regarding the critical amenities and the procurement status. This is in nutshell regarding the procurement of personal protective gears, which I have detailed earlier. From the limited words, what I can speak to the world, the audience, the opinion pollers, rather the experts over here, the take-home message, the lessons for the Kerala Medical Services Corporation out of this particular episode, rather, COVID pandemic, is that preparedness and practice are the backbone for everything. Built for today and ready for tomorrow will be the weapon. And act with speed and confidence, however the bad situation is, will be the motto behind the mission. Thank you.
Thank you, Dilip. First of all, let me apologize, Dr. Ajit Abraham. In fact, there are a few more minutes which we will be taking. I'll request Dr. Arvind to make a very broad points rather than going through all the presentations. So over to you, Dr. Arvind, quickly.
Good evening. I will be touching upon the state-specific, the clinical challenges we faced and how the state mounted a preemptive, proactive, calibrated, and graded response. As mentioned, the considerations were the demographic vulnerability. The density of population in Kerala is twice that of the national average. We had around 50 lakh elderly to take care of, and we are the capital of diabetes and hypertension, the prevalence being around 15 to 20% in the community. And if you look at the epidemic curve, till around May, we were successful in flattening the curve, and we were lauded by the world for that achievement. But what happened after that? The curve slowly rose, and as of now, we are having around 1 million cases in the state. But then the most interesting aspect is that the case fatality rate remains pretty low. That is, the case fatality rate 6 months back was 0.4, and through meticulous planning and execution of our policies, we were able to maintain the case fatality rate still now at 0.4. What led to the peak in the number of cases was once the relaxations occurred, with regard to the travel restrictions and all, 9 lakh expatriates came back to Kerala, and 11 lakh people, the Malayalis from across the nation, returned to their homeland, and we welcomed them with both hands. And because of this 20 lakh expatriates, definitely our the zero prevalence and the case numbers did go up. But even after 1 year, you can see that the zero prevalence in Kerala as of December is only 12%. That's half of the national average. And that means that we were able to protect around 88% of our population from getting infected even after 1 year, and despite our demographic vulnerability. This is actually achieved by, next slide please. This is actually achieved by coordinated action. So we understood that since we are dealing with a respiratory virus, so this battle is actually a long-drawn fight. It's not going to be a 100-meter race. It is going to be a marathon. So what we decided was to establish centers of care in all districts, even from the PHC level onwards. We instituted the decision-making bodies, that is the medical boards at all the treating hospitals, along with the district medical boards who were supervised by the state medical board. And then the state medical board came out with all the treatment policies for testing, the clinical management, as well as infection prevention control. And the policies were based on intensive real-time logistics and resource mapping. We adopted best practices from successful models across the world. We adopted epidemic intelligence as well as probability-based modeling. And we actually did frequent introspection through SWOT analysis. And we were the state which came out with the treatment protocol in the nation. And most important aspect is that even 2 months prior to the WHO advisory of universal masking, the state did adopt universal masking. And ours is the treatment protocol which comprises the care of the pediatrics, the critical care, as well as the treatment of MISC and MISC, etc. And our protocol is updated in a timely fashion. The most important aspect as far as the protection of the protectors is concerned is that our case fatality rate among healthcare workers is just 0.06. You can see that the healthcare worker mortality is probably the lowest in the world. And as far as our cumulative death analysis is concerned, we take our death analysis very seriously, because only then we can improve ourselves. Even in people above 100 years of age, our case fatality rate is only 6%. But what the world looks at us is how we protected the patients without COVID also. We need to look at the COVID case fatality rate as well as the cumulative case fatality rate which occurred during 2020, and Kerala happens to be the only state which has come out with the excess mortality data which was published recently. And you can see that in 2020 compared to 2019, the case fatality rate, that is the total case fatality rate, did come down by 11%, and the crude death rate in 2019 per thousand population was 7.5, whereas in 2020 was is 6.8. There was a 0.7% reduction, and this was actually achieved by meticulous planning. Next slide, please. And we know that the 5-tier, the concept of care, that is a seamless transition from the home care to the ICUs, has been made possible by the decentralized as well as the centralized nature of our response. And nowhere, even when the total number of cases per day happened to be 12,000, our ICU occupancy was maximum at 70%. So it was through meticulous planning that we ensured that none of our patients were denied care, despite of the age, was denied care in the ICUs. All of them were treated pretty well. And looking at the psychosocial support which was offered not only to the patients in quarantine, also to the patients. So we had till now made around 70 lakh calls to the patients in quarantine. And the most important aspect is, since we are having the variants of concern floating around, we have Kerala being the first state to set up a unique surveillance program to adopt the molecular contact tracing platform. Thank you very much.
Thank you. Now I will show some few slides related to analysis rather than, in fact, unfortunately, we had to rush. So when an epidemic happens all over the world, we are seeing three indicators. One is daily number of tests performed, how many positives are coming daily, and what is the test positivity rate. But these three indicators, in fact, sometimes suffer with the biases, because in various geographies, if the infrastructure is at variance or the number of tests performed are at variance, we will get a different result, and therefore comparison doesn't become very robust. And therefore, as my colleague Arvind spoke, in fact, we take a look at what is the all-cause mortality. And he has already explained. But here, in fact, one point we can say that, perhaps one will say, because the whole world was in lockdown, therefore, road accident cases, that is a contributing factor, and therefore we are seeing the dip. But most important factor is even the non-COVID deaths are part of this all-cause mortality. And therefore, if the system is having a resilience, if the system is responding to the requirement of the patient and the system is providing it, definitely the places will show the mortality is coming down. Then few other graphs which are, in fact, Dr. Balram sir has told us about the serosurveillance done in the country. And if we look at the Kerala, in fact, the first surveillance when it was done, in Kerala it was only 0.33%, and at the national average it was 0.73. So therefore, in fact, we can very well see the curves were different. If we take a look at the second serosurveillance which was done, it was 0.8 in Kerala compared to 6.6 in August. If we take a look at the mobility pattern in Kerala and in all over India is more or less same. It is not different, except in a mobility in the park related thing. But what point we are trying to highlight here is the serosurveillance in December also done. National average is 21% plus, and in Kerala 11.6%. So that means throughout the year, from 30th of January till December, all the people, it was public-led action, what is we have heard from our field level officers, and therefore we see the seroprevalence only to that extent, and remaining population is still vulnerable for infection. But as our Honorable Minister has said, what are the choices before the management? Whether we would allow the virus to go through, and the place like Kerala where it is highest density of population and having highest burden of disease in terms of diabetes and hypertension. In fact, it is a fundamental risk which any program manager, or for that matter, political executive would be taking. And therefore, Kerala, as a imbibing principle all throughout last 2 decades, we have been giving continuous effort on prevention. So during COVID pandemic also it was done, and public have been showing that, and Kerala is now well placed to be going forward with the vaccination program. So death related thing is already spoken, I will not think. So what we want to tell, in fact, I'll go back on 8th May 2019, Honorable Minister took a meeting, and this is the decision we have taken on 8th May 2019. We discussed how Israel does the mock drill annually. We discussed how Japan has taught the school children in case of earthquake what is to be done, and annually, in fact, they do the drill. So we discussed those case studies, and we decided to prepare a protocol for the mock drill for handling epidemic outbreaks of usually noticed diseases and rare epidemics, and conduct one mock drill in a year throughout the state in all the pit cell which are functional in all the medical colleges, and district surveillance unit at the district. We launched Aradharam People campaign. We launched, in fact, Jagrita campaign. So what we are trying to do in the state is active actions and not the reactive response. We take evidence-based dynamic actions, which is not, once the strategy is fixed, it is not cast in iron, and we keep looking at the data, and our epidemiologist and our state medical board keeps giving us the response, and based on that, we change our strategies, which is locally specific, and all the field offices at the district level, they have been given that freedom. Kerala is doing zero surveillance in all 14 districts. We will declare the result in the last week of February. Genome study will be out in all the 14 districts by end of March. So the feedback loop, what we heard in Madam Dr. Maria's presentation, we are practicing at the state level. So we have heard what we have been planning during pre-COVID period and COVID period related thing, and we are now strategizing about work around COVID. So what are the way forward for us? Back to the basics, surveillance strengthening, variants and immune escape cases, prevention of community spread of such variants, and going ahead with the vaccination. And the last point is, in fact, we are looking as a long-term plan, and we have taken an initiative. Our Honorable Chief Minister has guided us, and under Rebuild Kerala, we are taking this One Health initiative with the assistance from World Bank. Thank you very much. Once again, I apologize, Dr. Ajit Abraham, for encouraging upon his time, and I'll request Dr. Indu to come forward and very quickly, in fact, complete the introduction, and then we will request Dr. Ajit to start his speech. Over to you, Dr. Indu.
Thank you, sir. Crisis leadership and workforce resilience is the next topic, which is closely related to the session that we just now listened to. How leadership mattered, how workforce resilience mattered. We would now listen to Dr. Ajit Abraham speaking on the same topic. He is a trauma surgeon at Barts Health London with the National Health Service UK. He's also the Associate Medical Director for Improvement Innovations. He's the principal of the Staff College for Leadership in Healthcare. So he's both a HR manager as well as a surgeon. I also invite Dr. Tony Lawrence, Assistant Professor in the Department of Community Medicine, Medical College Trivandrum. Over to you, Dr. Ajit Abraham. Crisis leadership and workforce resilience.
Thank you very much, Dr. Indu. Can you hear me?
Yes, we can hear you. It's very clear.
Thanks very much. Good evening. Namaskaram. Ningal ellarum avade sugavayittirikunnu njan karudunnu. As a son of Kerala, it is a great privilege for me to have this opportunity to speak to you, and I'm very grateful to my dear friend Dr. Rajan Kobragade for the kind invitation. I know that he in his own way has been demonstrating exemplary leadership in the context of everything that's been happening. I'm going to give you a slightly different perspective because I'm not an expert epidemiologist or a public health expert. I'm very much a frontline clinician with some organizational leadership roles. And so I will try to give you that perspective in terms of what that has meant for our own crisis leadership here in the UK and some of the implications for workforce resilience. And I hope you'll find that useful. So let me say at the outset that everything that we've heard just reflects once again on what has been an outstanding response by Kerala to the COVID pandemic. And not just me saying this, but certainly well recognized in the United Kingdom under the leadership of the Honorable Health Minister, and some of the outstanding results that you've achieved and that we've just heard about are just immensely inspiring. And there is much for the United Kingdom to learn in terms of its public health approach to the COVID pandemic. We ourselves, as you can probably see, have had a bit of a battering. We had a first surge at the beginning of 2020, around February, March, and then subsequently you can see this very high peak that we've experienced over the last 3 or 4 months. Thankfully, you will see that all of the graphs are showing a reduction, and there is some light now at the end of the tunnel with a reduction in the R rate and an improvement in our vaccination rates, but there is no denying the impact it has had on all of us in terms of NHS provision. Just very briefly, I am, as Dr. Indu said, one of the consultant surgeons, a trauma and a hepatobiliary specialist at Barts Health. And Barts Health is actually one of the largest acute trusts, merged trusts in the UK now. We have a huge footprint. We, interestingly, if you look at the top right-hand pictorial depiction of socioeconomic deprivation, sit right in the center of that hot red area. And therefore, we have a very diverse population, significant socioeconomic deprivation, and a very dense population, all of which have contributed to us having a very significant hit during this pandemic. And the lower graph just demonstrates that as you migrate towards the population that we serve through Barts Health, you find a significant reduction in life expectancy as well. This is our own data in terms of what's been happening with regard to COVID, just high-level data. And you can see that there has been a very significant demand for general beds, patients requiring high oxygen flow, and our ventilated beds as well. So I'm going to look at this from the perspective of what it's been like, not so much from the test and trace and public health perspective, but what it's been like for us on the front line in terms of our treatment response to what has been a massive pandemic crisis. And one thing that I would say is that what has been very tangible is a shared sense of purpose, which has been helpful. I mean, the National Health Service was set up to provide universal access for all in high quality care, which is patient-centered, based on patients' clinical need and independent, I stress, of their individual ability to pay. This is something I think we are as staff and as a population very proud of. And that is something that has driven some of the collective collaborative response that we have been privileged to see. Just to highlight one sort of area where you get a sense of the scale of the crisis and how much we've had to respond. If you look at the number of ICUs that we've had to expand the UK ICU capacity up to January 2020 by an extra 2,251 beds. Typically, an ICU will have 16 beds. And so we've built the equivalent of around 141 new ICUs. If you take our experience at Barts Health, we have ourselves quadrupled our ICU capacity over a 3-month period from around 40 beds to 160 beds. And this without the intake of any new trained ICU staff, because there are none available. And I think this reflects some exceptional crisis leadership. And a lot of these staff have come from people, even senior consultants like myself and colleagues volunteering as healthcare assistants and so on, just to maintain the staffing levels and ratios in a safe way on our intensive care. So this is something that we have done well, I think. So I, as was mentioned, am the principal of NHS Staff College for Leadership in Healthcare. This is an independent charity which looks to develop leadership in healthcare and draws a lot of its inspiration from the military model. And I will reference that very briefly in talking about crisis leadership. And we believe that in order to we must be the difference, if you like, that makes the difference. And that is a function of how self-aware we are, how well we manage ourselves, which then translates into our ability to lead teams effectively and lead systems. So it's very much a values-driven ethos, which is about service to others rather than self-interest. And I'll touch very quickly on this Center for Army Leadership model about leading in crisis. And again, as I said before, I think you've already demonstrated this in exemplary fashion in Kerala. I mean, all of this sits within the context, in this case, the pandemic. And clearly, we have a tripod of attention, if you like. We must look at the task that is in front of us, and there needs to be definition of purpose, clarity of plan, appropriate decision-making, and appropriate management of risk. There is a big piece around the individual leaders have to learn to look after themselves as well as the individuals in their team, and to be a leader with integrity and authenticity and humility and a willingness to learn. And clearly in the context of team, you can never communicate enough. There is a need to encourage challenge. So the importance of creating psychological safety within your teams is paramount. And we try to teach this, and also the importance of followership as much as leadership, and the need to learn from one's mistakes and new events. So one of the key things that I have noticed in terms of the way the NHS has responded to this crisis is that it has been forced, or at least impelled, to move away from a top-down approach. And it has very much been, at least in the frontline sense, a shift in emphasis to a mission command approach. And what I mean by that is, whilst there has been a stipulation of organizational intent, there has been a far greater reliance on the leadership qualities in the workforce. And I think this is a welcome change in emphasis. So there's been a devolution, and whilst the goals have been defined clearly, a lot of the authority for decision-making has been pushed to the front line, with management of the risk more centrally. And there has been a far greater degree of trust, I would say, with very little attempt to verify quite as much. And with it has come a certain agility and flexibility in terms of a mission command culture that I think has allowed us to mount the kind of intensive care type response, rapid quadrupling of our capacity in a very short period of time in innovative ways. And so that, I think, is welcome. This paper from the King's Fund, I think, really highlights what I think are 5 very significant paradigm changes. Again, I suspect Kerala is ahead of the curve on some of these things, but certainly for the UK, some very welcome and long overdue, I would suggest, paradigm shifts in our thinking. So the first is a recognition of the impact of inequality on population health and on healthcare outcomes. And this I think is hugely important. It's reflected in the Marmot Review 10 years on in terms of the social determinants of health. And I think that's a very positive thing. In addition to needing to clearly reform social care, increase investment, and improve collaboration with the communities and public services, I think there has been an obvious shift in the embracing of digital technology to improve care in ways that previously were perhaps tied down in bureaucratic red tape and governance issues, and an excessive consideration of risk, perhaps. But most importantly, there's also been a very clear recognition that we have to put our workforce center stage in the UK, and that we have to ensure their joy at work if we are to ensure optimal care for our patients. So to touch upon these things very briefly, just referring back to this King's Fund paper, it highlights the kind of stages and the emotional ups and downs that individuals and teams and organizations even go through in a pre-disaster, post-disaster phase. And it shows that it's a pretty up and down journey, and that it's also spread over a significant period of time. And this is recognized now in our organization. This is just a very high level schematic. I don't want to dwell on the detail too much, except to say that we have a very clear plan of resting and repatriating those who have been redeployed, followed by a period for reflection and recovery before we go on to restore services and redevelop them. The other thing that has pleased me is that we have integrated a quality improvement approach into the way we have developed some of our responses to the needs of resilience and well-being for our staff. We are strategic partners with the Institute for Healthcare Improvement in Cambridge in Boston, and we utilize the model for improvement, but this just merely illustrates the breadth of work that staff have been doing to co-design and co-create and test new and innovative ways of developing staff resilience and supporting well-being, which I think, again, has been a great positive. You are all, I'm sure, familiar with some of the psychological PPE measures that can be applied, simple measures in terms of both individuals and team leaders. And on the right, you will see a lot of the stuff that we are doing at Barts Health in this regard, and not just at Barts Health, but across organizations all around the UK in the NHS. And it ranges from simple things like providing warm food and water and the very basic Maslowian needs in terms of the hierarchy, right up to embedding clinical psychologists within teams on the front line and ensuring that there is psychological first aid and appropriate coaching and psychological counseling as required. So there's a huge raft of things. A couple of things that are very dear to my heart. I've had a long-standing yoga and mindfulness practice for over 30 years, and I'm very delighted to see that we're now even offering yoga sessions before the start of some of our theatre sessions for staff, and this is continuing despite the drop in the surge or the second surge. And more importantly, also, I'm pleased to have been part of introducing mindfulness practices at work within the organization using a simple RAIN methodology, which is about recognizing, accepting, and investigating non-judgmentally, and then being nurturing towards self and to others. So this is all becoming mainstream, and a lot of what used to be ancient Indian wisdom and considered esoteric is rapidly becoming mainstream and is very much evidence-based too in many ways, which is very, very heartening to see. And the other thing that has been pleasing from a UK perspective is that there's been a lot of learning, and some of the mistakes made during Surge 2 have certainly informed the redeployment in Surge, made in Surge 1 have certainly improved the support for staff who are redeploying in Surge 2. Again, I won't go into the details, but the competency training, the supervision of redeployed staff, identification early on with risk assessment of equity issues in terms of staff to be redeployed, linked health and well-being, pastoral care, and much improved communication have all been significant improvements and learning from the first wave compared to now the second wave. So that's a big positive. I'm very pleased to be co-chair along with my group CEO, Dame Orwin Williams, of our inclusion board for the entire organization. And we have a We Belong strategy. And one of the positives of this COVID crisis is that it has made very acutely clear to people the impact of inequity on healthcare outcomes, and the fact that in not being inclusive as an organization can have adverse outcomes for both staff and for the patients and families and communities that we serve. So this is in some ways a silver lining in terms of what has happened during this pandemic. We have a very elaborate strategy. I won't go into too much detail around it, except to say that clearly we now accept and recognize, not just on paper, but in terms of the way we are rolling out some of our actions, that inclusion, you can't have well-being without inclusion. And so there is a lot of emphasis through the board that I help chair around measurement of staff data, staff experience data, and patient experience and outcomes, which I think augurs well for the future in terms of our inclusion and equity agenda. And lastly, I think this may have some relevance in the context of the Kerala efforts. We recognize that as a major employer and major footprint, having a major footprint in the East End of London, we are effectively an anchor organization, and we have a significant role beyond the provision of healthcare to provide healthier communities. And so some of this relates to our work on reducing our environmental impact, increasing the greenness of our offer, widening access to work for a lot of our colleagues, purchasing locally for social benefit, and using our buildings and our spaces to support communities. So this, I think, is a very positive development, and we have in the process of building an allied inclusion center and a community connectivity center and inclusion observatory for the measurement of race and equality data. I will end very quickly with a quote from my mentor, Professor Aidan Halligan, who founded the Staff College after his experience of military leadership in Afghanistan. And he went on to say that leadership is really about doing the right thing on a difficult day. I think the NHS can be proud of a lot of what it has done, certainly in terms of the treat phase in its response to this extreme COVID challenge. And it goes without saying that the Kerala response has been an exemplary example of leadership doing the right thing on a difficult day. And for that, I applaud you. Thank you very much.
So that was Dr. Ajit Abraham, consultant hepatopancreatobiliary and trauma surgeon, the Royal London Hospital, Barts Health NHS. Thank you very much, sir, for that excellent presentation. And thank you for the amazing work at the NHS and leading the world as among one of the organizations that leads the world. And that is one of the aspirations of Kerala Health also. Thank you for mentioning in detail about the managerial approaches in extreme events, the emotional highs and lows during crisis, human recovery and restoration, which we really need, the psychological PPE, we have heard about the physical PPE. This is very much needed for our restoration and living with COVID. dedicating time to the well-being and wellness, about mindfulness and supporting our staff. Thank you very much. We have a few questions, sir. If you could guide us. With the pandemic, we have seen the change of our roles and responsibilities with our expectations and deliverables. In a crisis, how do we restructure this and reorganize to face this crisis? Over to you, sir.
So I think this has been one of the great learnings, not just for me personally, but for us as an organization and across the NHS, because the need to redeploy at pace has meant that people have had to completely rethink and reinvent their roles. And I think one of the great positives that has come from it in terms of multidisciplinary and multi-professional working is that you learn some humility in learning to respect the expertise that other people bring to the table, because it's only when you walk in someone else's shoes and do their job that you understand the intricacies of that job. So working, for example, as a healthcare assistant myself, or as a first line nurse in intensive care, taught me so much about intensive care that regardless of me being a consultant, I did not know myself. And I think that has led to a genuine flattening of the hierarchy within the NHS and a better understanding of how people can work together. So I think that will augur well for the future, even when we redeploy back to our original roles, as I have done, for example. It does impact favorably, I think, on the way we work together in the future in terms. So I don't know whether that addresses your question, but I think I see that as a big positive.
Okay, thank you, sir. Regarding interventions for family along with the healthcare workforce, what are your suggestions, sir?
So a lot of what is currently happening is also linked to an outreach program in terms of the community. So that community center that I talked about, there's a lot of community engagement projects going on. There is a faith outreach program. So we have a very significant Muslim population in the East End of London. So it's a mix of Jewish, people of all faiths, Jewish, Christians, Muslims, a bit like, I guess, and Hindus actually. So it's very much like Kerala. And we have got a lot of faith outreach and a lot of community outreach. And that is being supported through our education academy with sort of psychological counseling and psychological outreach as well. So there's a lot of community outreach happening, as I'm sure is happening in Kerala too. Yeah.
Thank you, sir, on behalf of Kerala Health.
Thank you very much. Thank you for having me.
We move on. Pandemic and preparedness. The panel with three very eminent experts. Actually, viewers are looking forward to this session. It's a futuristic overview of how we go ahead. The panelists are Dr. Gagandeep Kang, Dr. Jacob John, and Dr. David Wilson. We'll start with Dr. Gagandeep Kang. Professor Kang is Professor of Microbiology at the Wellcome Trust Research Lab, CMC Vellore. She has been the Executive Director of Translational Health Science and Technology Institute, Faridabad, an autonomous institute of the Department of Biotechnology, Ministry of Science and Technology. She has been working with the epidemiologists, with various field epidemiology aspects, with intensive lab investigations, and that makes her a real expert in this field, which Kerala looks forward to. Over to you, Dr. Gagandeep Kang.
Thank you very much for having me here. I'm going to be speaking to you very briefly about pandemic preparedness and vaccination-related questions, and then we'll move to other questions with the rest of the panel. So if we look at pandemic preparedness, a year ago, I guess many of us had just about begun to think of vaccines. And we are in a situation now where vaccines have already been rolled out. And this has never happened at such scale with so many different candidates and so fast. So there are a lot of doubts in people's minds. about what we should use, when we should use it, how we should use it. Are there other things we need to know? And I think as a scientific community, it's very important to recognize what we know and what we don't know and communicate that clearly so that people understand how decisions are really made. So if we look at the landscape of vaccines, we have over 200 that are in preclinical testing, 37 that are in early phase human testing for safety, 20 that are looking at expanded safety and immunogenicity, 6 vaccines that are in phase 3 efficacy studies, and there are a number of vaccines that have been approved for full use or for partial use. And among the vaccines that have been approved for full use, those are the vaccines from Pfizer, Moderna, AstraZeneca, known in India as Covishield, and the Gamaleya vaccine. There are 2 other vaccines that have been licensed for use in some countries, but still limited licensure. And those are the adeno candidate from CanSino Bio and an inactivated vaccine from Sinopharm. We also have a restricted use approval for the Covaxin vaccine, which has not yet completed its phase 3 trials. So if we look at how much vaccine there's going to be in the world and whether this is going to be a solution for us and in what kind of time frame, it's important to understand how much vaccine can be made. It was estimated in May of 2020 by the Coalition for Epidemic Preparedness Innovations that we could have a production capacity of 2 to 4 billion doses in 2021. That estimate has now been revised up to 6 to 9 billion doses. And it's likely that we will be somewhere near the lower end of that mark, given that there have been some glitches in vaccine production, particularly for the vaccine candidates that were first off the mark for mRNA vaccines, and then some with the adeno vaccines, for example, Johnson & Johnson. So these are all the various platforms for making vaccines. There are the vaccines that depend on either giving the whole virus or parts of the virus, which can be live attenuated or inactivated vaccines, vaccines that are virus-like particles, or vaccines that just have protein components of the virus. And in the case of SARS-CoV-2, we know that the spike protein is most important to focus on. And we know this because there was a lot of effort that was put into developing vaccines for the original SARS and for MERS coronavirus, which is one of the reasons that we were able to move so quickly with the development of vaccines for SARS-CoV-2. The other class of vaccines that we have is where you don't give parts of the virus or the whole virus, but you send in the message of how to make viral proteins. And vectored vaccines, DNA vaccines, RNA vaccines are included in that category. So all of them carry the message for the spike protein, and that is delivered into the host cell, which then produces the protein to which the immune system responds. So we know that we have a lot of vaccines, and this is figures from around the world and from our world in data, looking at cumulative COVID-19 vaccination doses administered. And in that categorization, India ranks 4th, with the United States, China, and the United Kingdom being ahead in terms of absolute numbers. If we look at, however, the number of doses given per 100 people, which is a measure of the rate of vaccination, then India is vaccinating at a relatively slow rate of approximately, it's about 0.1 per 100 people. If we look at how many vaccines have been administered and where they have been given in the country, just in terms of absolute numbers of doses, the maximum has been given in the state of UP, and there are limited in some parts of northern and central India. However, if we look at how many vaccines have been given per million people, we can see that that presents a very different picture. The numbers, the absolute numbers are high in UP because they have the maximum number of people in that state. So just to come to, that is the scene for where we are with vaccines globally, but what are the kinds of questions that people are asking that are related to vaccines and vaccination? And I've limited myself here to top 10 questions. I think given the fact that we are going to have many more vaccines, and we don't have the ability to test all of them in phase 3 clinical trials that require tens of thousands of participants, we really need to understand what is the correlate of protection. What can we measure that will tell us whether the vaccine will work or not? And this is going to be important for seeing who is protected. And with the introduction of variant strains, this is going to become even more important. Can we use the same correlate for all viruses, and can we use that for all vaccines? We still don't know what are the long-term safety considerations for vaccines. Most vaccines are very safe in the long term, but this is something that needs to be documented. We don't know how long protection will last. It's estimated that it may be up to a year or 2 years. We can hope that it is longer, but until we measure reinfections in vaccinated populations, we will not know that. We don't know yet whether vaccines protect against infection. There are some indications that for some vaccines, there is a reduction in transmission. And the AstraZeneca vaccine, the early data seems to indicate that there may be some protection against infection. But as yet, for many of the vaccines that we've started to use, we have not even seen all the data from the phase 3 trials, let alone the data that will allow us to understand how these vaccines can be used as public health tools. They do protect against disease, which is very important, but we need an understanding of protection against infection and against transmission. Then the big question that everybody asks, which vaccine is best? Right now, we know that all vaccines are meeting the bar that the WHO had set, which is that all vaccines should have greater than 50% efficacy wherever they have been evaluated in phase 3 efficacy trials. Either all vaccines have passed that mark. The vaccines where programs have been abandoned at earlier stages. There are questions about whether previously infected people should be vaccinated, and France has decided that they will give a single dose to people who have a history of infection. And that is an approach that could be supported based on our understanding of immune responses. Will all vaccines work in the elderly? I think this is an outstanding question, particularly given the fact that Germany and a few other countries have decided not to use some vaccines in their elderly. But I think we should understand also that all vaccines work a little bit less well in the elderly. There are questions now about whether vaccines can be mixed in a multi-dose schedule, and the UK is doing some studies to try this out, and I think we should be doing such studies in India as well. Will vaccines work against variant strains? How frequently will we need to change vaccines? We already know that against some variants, like the UK variants, most vaccines are working, but against the South African variant, we are seeing more variable results. So I think this is something that needs to be tracked and understood over time. And only with time will we understand also how frequently we will need to change vaccines. I hope that it will be every couple of years or so. So facing forward, we have a lot of vaccines in development in India on multiple different kinds of platforms. Our vaccination program is in a state where it is now delivering vaccines to adults and to populations of adults where we have not done this in the past. So there really is a lot that we have done so far, but there is a lot more that we have to do in terms of surveillance capacity, and Kerala has established an institute for virology, which I think is a great first step. And I think the government in its budget has announced new institutes for other parts of the country as well. But the Kerala government did this following on Nipah, which I think is very prescient. And we need to be thinking about building resilience, building equity in health. And for the next pandemic, if we focus on these tools and on the science and the technology, I think we will have vaccines in 6 months or less. So thank you very much for your attention.
Thank you, Dr. Gagandeep Kang, especially for coming to equity from all the sciences. We'll come back to you after listening to the other panelists. Dr. Jacob John is a renowned pediatrician come virologist and is former professor and head Department of Virology and Microbiology at Christian Medical College, Vellore. He was the head of Indian Council of Medical Research Center for Advanced Virology. He is a vocal advocate of public health surveillance, smarter use of diagnosis tests, and government decision-making transparency. Over to you, Dr. Jacob John.
Thank you very much. Why is my video not visible? Yeah, now it's okay. Thank you, Dr. Indu. Fellow panelists, ladies and gentlemen, it's a singular pleasure for me to address this very visionary seminar. In the next 10 minutes, I will address two issues, two questions raised, one COVID epidemic specific, and the other about balancing logic and evidence in a crisis situation. Although I was asked to touch upon how Kerala should move forward, I do not think that that is necessary. On the other hand, what I will do is to tell you how, from outside Kerala, I look at Kerala and Kerala's experience with COVID epidemic handling. Kerala taught the rest of the Indian states how to be proactive, anticipate virus importation, test, quarantine before release, contact tracing, soliciting and getting people's participation, full participation, getting the healthcare institutions in public and private sectors to function smoothly, and really flatten the epidemic curve in the early months. However hard we try, this is a respiratory transmitted infection, and it was inevitable that Kerala had to face a second wave. Second wave is a function of the relative proportions of the infected to the uninfected. Flattening of the curve means a larger proportion is left uninfected and susceptible, with an agent having a basic reproduction number, or R0, about 2, high population density, hardly any gaps between habitations. Second wave from which Kerala is recovering now was inevitable. In the absence of public health surveillance in India, and I will return to this item later on, we are totally in the dark about the real numbers in India, the magnitude of the epidemic, and the total mortality. A comparison of various states tell us that the infection burdens, as reported, per unit population vary very widely by a factor of 100 between the lowest and the highest. It speaks volumes about the lack of real data. The credible data are on deaths because they are among those detected infected. So the denominator is fairly clear. And that case fatality as of yesterday, the total case fatality so far was 0.396 in Kerala, 1.3 to 1.7 in Tamil Nadu, Karnataka, and Delhi, 2.49 in Maharashtra. So Kerala's health care has been exemplary in spite of 4 adverse factors. As already mentioned, high population density, the longest life expectancy among all Indian states, high prevalence of non-communicable diseases, and unfairly large diaspora who had to return to roots back home. Kerala can continue to play a leadership role by model building and upscaling models. How can we balance science, logic, evidence within health management? Now, healthcare demands evidence-based responses, which is a mistake that many other states in India did, always a step or two behind the virus, because evidence-based response is reactive, not proactive. It is public health alone that can be proactive by anticipation, and Kerala instinctively adopted that approach. And I will venture to say that it was because of the Nipah virus epidemic in 2018 and the exemplary manner it was handled by Kerala. All states, including Kerala, used ad hocism, inevitably so, because no state practices true public health in India. Health management requires 3 elements in modern medicine: public health, healthcare, and research. Kerala can design and demonstrate the profit we can get through investing in public health. In 2011, Kerala government allotted 110 million rupees for creating a health protection agency, which was proposed by myself and Professor Biju Soman of Achutamanan Health Sciences Center in Thiruvananthapuram. But for a decade, that fund remains unutilized. Both of us, Biju Soman and myself, will be quite happy to help design a health protection agency in Kerala. Now, health protection agency is a synonym of public health. That name is preferred because healthcare experts use public health to mean public sector healthcare, very different from public health. So health protection agency is a preferred terminology. With a health protection agency, we can introduce public health surveillance, which we miss badly in every state, including Kerala state, which is necessary to become prepared for controlling Endemic diseases such as typhoid fever, hepatitis A, chickenpox, dysenteries, leptospirosis, all this can be controlled once we have public health surveillance. Once we have created such a platform, we will be able to face any pandemic in future. And pandemics are likely to come at unexpected moments. Kerala is vulnerable to many zoonotic diseases, particularly with we are in the shadow of the Western Ghats, which makes us vulnerable to many zoonotic diseases. So we need one health approach, as I already mentioned before. I have created a logo for One Health for Kerala, and I have shared it with Dr. Srikumar of Rajiv Gandhi Institute. I didn't want to show it to you here. Once you have a One Health agency, you need a lead agency to create that, and the Health Protection Agency can play a leadership role for creating One Health. Thank you very much.
Thank you, Dr. Jacob John. We'll come back to you with some queries. Please stay with us. Dr. David Wilson is a program director in health, nutrition, and population practice at the World Bank. He is team leader for the COVID-19 Fast Track Facility and Health Emergency Preparedness and Response Fund. He has vast experience in working in all continents in around 65 countries. Over to you, Dr. David Wilson, our third panelist for the session.
Thank you very much indeed. I'm not able to switch my video on because it's disabled by the host. So I'm happy to talk if you can hear me. And if you can switch the video on, that would be great. Can you hear me okay? Oh, okay. I've been permitted to start my video. Thank you very much indeed to the host. And thank you for this opportunity to participate in this seminar. And I've been asked to focus particularly on the lessons of preparedness. And let me begin by saying that it is customary to bemoan the cycle of panic and then neglect. Panic during the pandemic and then neglect after the pandemic. And this is undoubtedly true. And we do need to ensure that the preparedness momentum generated by COVID is not lost. In short, we need to ensure we do not perpetuate the cycle of panic and then neglect. At the same time, I do believe that this momentum will need to be matched by a much more deliberative analysis of the lessons of this pandemic. And I say this because many of the countries who have invested most in preparedness before COVID have been amongst those hardest hit by COVID in terms of both cases and deaths. And we've also seen that countries with the highest WHO Joint External Evaluation preparedness scores, specifically the US, the UK, Netherlands, Sweden, and France, have also been amongst those hardest hit by COVID in terms of both cases and deaths. And we've also seen how much instant public health and epidemiological interpretation has been almost immediately contradicted by unfolding experience. And this isn't surprising. What we've experienced is unprecedented. Almost the entire world has stopped and focused on one issue. And what we have seen is that countries who are judged to be at greatest risk, for example, many in Africa, were initially less affected than feared. And countries judged to be successes have sometimes immediately experienced major waves, often immediately after their coronation as successes. And just consider how Germany's very widely and justly praised response, led by its world-class testing program, was unable to prevent a large recent wave. And at the risk now of adding to the discredited instant epidemiology that I've described, let me suggest the following, which really builds very much off the previous speaker's remarks, and to me, the clearest conclusion is that countries that moved to institute comprehensive border health security, including border closures and quarantines between countries and within countries, before they experienced significant transmission, have fared best. And the countries of East Asia, which have had compulsory supervised quarantine from almost the outset of this epidemic, and the islands of this Pacific exemplify this lesson. And I think that's one of the many reasons why islands have fared better in this pandemic. I know of no other factor which emerges with such clarity. So I do think the lesson that we can generalize from this epidemic, as Dr. Don suggests, is act early and act hard. And it is true that traditional cordons sanitaires have been vital in nearly all epidemic responses and have served countries in East Asia and the Pacific well too. I do think, as Dr. Kang has ably illustrated, that science has been the standout star of this pandemic, and our investments in science have reaped enormous and fast benefits. And simply consider that the virus was gene sequenced on the 11th of January last year, within weeks of the virus being discovered. And this really gave rise to the unprecedented vaccine progress that Dr. Kang also illustrated, with Moderna essentially writing their vaccine within 48 hours of the gene sequence. I do think in terms of global preparedness, manufacturing and manufacturing chains have been less successful. And I do believe we've realized how concentrated and fragile our global supply chains are. We saw this for PPE and for diagnostics, and we're now seeing it for vaccines. And simply consider the recent European Union disputes over vaccine manufacture and distribution. And I do think that this will change now as more countries will require vaccines for their own variants and will be reluctant to entrust them to manufacturers thousands of miles away. As Dr. John said, we undoubtedly need pandemic surge capacity in so many core public health functions to track, trace, quarantine, isolate, and to treat. And as an earlier speaker from London said, we need better surge capacity in urgent and intensive care. And I suspect this public health and this urgent care surge capacity will be most durably provided by multi-skilling existing health workers and by ensuring their preparedness skills remain refreshed and current, even during times of peace. And I think this will be an enormous post-COVID priority for health systems. I do think that health systems that focus successfully on fulfilling the moral mandate to provide universal health care were not necessarily best prepared to return to core public health functions in times of pandemic battle. We're going to undoubtedly need a greater global genomic capacity, and Dr. Kang touched on this. And it's remarkable today that the United Kingdom, with 60 million people, does over half of the world's genomic surveillance, over 210,000 genomes sequenced. And in Africa, South Africa does nearly all of Africa's genomic surveillance. And it's no surprise that these two countries have identified variants of concern that have become associated with them. But it's almost certainly because of their greater genomic testing. And for example, the UK has found far more people who have the variant of concern first identified in Nigeria than Nigeria does itself. And it's remarkable that the UK and South Africa have done this by building networked capacity, by essentially recognizing that most genomic capacity resides in university laboratories and creating large national networks of these laboratories to provide genomic capacity. And as I move to concluding, we also need far greater coordinated crisis response in governments, whether for disasters, emergency, or pandemics. And this will need to be a core government skill, and we will need to build the crisis response institutions that Dr. John spoke about. Let me conclude by re-emphasizing my first point. We undoubtedly need to ensure the momentum of COVID allows us to break the traditional cycle of panic and then neglect. But we're also going to need to ensure that the key public health lessons of this pandemic are carefully and deliberatively appraised after the pandemic, so we learn and apply the right lessons. Thank you very much indeed.
Thank you, Dr. David Wilson. We'll have a quick round of questions. First to Dr. Gegadeep Kang. I have two questions. I'll quickly ask both. Please respond. If there is a province, state, or country which keeps their population at a low prevalent rate, I mean, we can say they're sanitizing the entire population due to various interventions, will it not be logical to give them a priority in vaccination or an urgent vaccination so that the vulnerable, the proportion of vulnerables will come down? That's the first. Second is in relation to genetic variations. How genetic variants are to be addressed while developing vaccines? Dr. Kang.
Thank you very much. Both very important questions. And to take the first one, essentially you're talking about a population to which good routine public health can be delivered, which results in control of virus transmission. Given that they've already been doing a good job, should they also not be prioritized to receive the fruits of science, which is vaccination? And I think this is something that has been discussed, and in a time when vaccine supply was unlimited, that would make a lot of sense. But where we are today, when vaccine supply is limited, the approach has been to target as priority groups the people who are most at risk of infection, severe disease, and mortality. That's why the prioritization has been recommended by WHO and agreed by the government. But if we follow principles of who should get vaccine, then absolutely the ones who are most unprotected, and that would be the case of your population that restricted spread, it would make a lot of sense to go that route. Your second question related to variants and vaccines, actually, it's becoming a lot easier to make vaccines quickly, and especially if the vaccines are vaccines that rely on the message and not on the production of proteins. Those vaccines can be designed in a weekend, as David described for the Moderna vaccine, but also made within 6 weeks. So our ability to respond quickly has completely changed, and how we will be able to handle variants. I think that's one of the reasons why we need to understand variants, but also understand that we can more easily address variants than most people think.
Thank you very much. Special thanks for addressing both horizontal and vertical equity as a response to your first question. Thank you, Kang. Dr. Jacob John. Kerala's current seroprevalence is 11.6%. How should Kerala move forward in this regard? You have already seen how our epidemic curve is, right? Due to several interventions, Dr. Rajan Kubragade and his team has demonstrated how the actions, and he has also shown the curve, which is actually keeping a plateau for quite a long time. Probably one of the unique curves. You don't see such a, I mean, there are very few examples where you have such a plateau. In such a situation, what should be the way forward? Still 88% is vulnerable.
Okay, when we talk about pandemics or infectious diseases, you must distinguish between pandemics that have a vehicle of transmission other than air and respiratory transmitted infections. Now, the coronavirus that we are facing now, the pandemic, is rather unique in the sense that other than SARS that came and disappeared like a meteor, almost all other respiratory transmitted pandemics have been influenza only. And influenza is a very peculiar infectious disease that the virus does not invade the tissue. It's a surface infection, and yet the body responds quite vigorously, and pathology is partly due to virus and partly due to the immune response. So here we have a respiratory transmitted virus that actually creates a metabolic syndrome like problem because it hits the ACE2 receptor, which is crucial for maintaining blood supply, oxygen supply to organs. So this is an unexpected turn of events. And so getting prepared for another pandemic, we need to understand the transmission pattern chains and pathophysiology very early in its onslaught. Now, let me just add one thing, that in China, I had noticed 2 pneumonias in October 2019 in a couple, husband, wife, in Inner Mongolia, northern part of China, with bilateral pneumonia that was unexplained for any etiology. Surveillance missed that. They were referred all the way from Inner Mongolia to Beijing. Still, surveillance missed it. So we do need to create a surveillance system. And my recommendation to Kerala is to create a model of public health surveillance so that we can look at all endemic diseases and any disease that is not diagnosed, and therefore it becomes a signal for trouble. So creating One Health because of the zoonotic disease risk factors, add a public health surveillance, together Kerala can build a model. That would be what I would recommend for Kerala, because the coronavirus infection is inevitable because it is respiratory transmitted. Whatever you do, the virus will find an escape route and infect people.
Thank you, sir. Thank you very much for that response. Actually, there are some initiatives towards those directions by setting up outbreak monitoring units as part of PCLs and medical college to identify the signals and triggers at earlier, the so-called syndrome X. Thank you very much, sir, to Dr. David Wilson. Preparedness for future pandemics. What are the new learnings from the current pandemic? You have already mentioned that the science is the star of this pandemic.
Yes, I think I've really answered that largely. I do think science has been the star. I very much like Dr. Kang's point about our scientific ability, especially with the messenger vaccines, to produce the vaccines very quickly. I'm a little more cautious about how quickly we can then manufacture and deploy them. So I think, again, science is ahead of other technologies. And for example, AstraZeneca believe that they'll be able to have their vaccine adapted and in arms for the South African variant by about August or September. And on the one hand, that's scientifically fast. On the other hand, that's a long time. And given all the bottlenecks in existing vaccine production, I think that manufacturing will be the bottleneck when it comes to deploying vaccines that have been developed for new variants. I obviously think we're going to move towards multivalent vaccines in future. And I think that will be an important development. So I would continue to say that I believe the science has outrun manufacturing. Sorry, and over to you.
Thank you very much, Dr. Gagandeep Kang, Dr. Jacob John, Dr. David Wilson. There were many other queries as well. Because of the lack of time, we are proceeding further. Let me now invite Dr. Ritin Kelkar, the State Mission Director of National Health Mission, to lead the next session where we will listen to responses from the district collectors on what happened as an epidemic response. We have Dr. Navjot Khosa, the District Collector of Trivandrum District, Mr. Suhas, the District Collector of Ernakulam District, and Dr. Adila Abdullah, District Collector from Wayanad District. Over to you, Dr. Ratan Kelkar.
Good evening. COVID pandemic has been catastrophic, not only economically, but also to the lives of people. And in this long drawn battle, at the end of the day, people generally latch on to something. And probably an inspiration is what that is needed for them to move on. Kobe Bryant has said, the most important thing is to try and inspire people so that they can be great in whatever they want to do. And in this session, we are looking at responses from the field, from the district where the COVID-19 management has happened. And we have with us three inspiring leaders amidst us who will be sharing their experiences on COVID management. We also have with us Dr. Gangedkar, who shall also be giving his remarks on the epidemic and the fight put up by the state of Kerala in this session. At the outset, let me briefly tell the participants the rules of today's session. The district collectors will be called in the following order: District Collector Trivandrum, District Collector Ernakulam, and District Collector Wayanad. They will all be making a presentation for 5 minutes. And after the end of the session, after their respective sessions, we will see if we have enough time for questions. And we will also be hearing Dr. Gangedkar, who will be giving his remarks in the session. So let me start by welcoming the District Collector of Trivandrum, Dr. Navjot Kosa, for her talk on the field work covering testing, contact tracing, surveillance, and quarantine.
Good evening, everyone. I'm Dr. Navjot Kosa, District Collector, Thiruvananthapuram. First of all, thank you for giving me this opportunity to share the district's response to COVID-19 on this platform. The topics I intend to cover are testing, contact tracing, surveillance, and quarantine. A quick glance to my district. Next, please. I have a population of around 3.2 million, and the total cases of COVID-19 positive cases, we are about to touch 1 lakh. We are at 99,527. The active cases as on date are 4,110. I have approximately tested 1/3 of the population of the district, and around 3% of the population has tested COVID positive till now. I have a current TPR, test positivity rate, of 4.8%. Next, please. The guiding mantra for the district has been to test early, to test early, to trace completely, and to isolate effectively. These have been the guiding mantra for the district. Previous slide, please. Previous, please. The highlight of the district's fight against COVID-19, which I'll be discussing in the forthcoming slides, is that we have a very dynamic surveillance strategy based on the epidemic status. That means that we studied the geography of the district and the demography, where all the density is high, where the population is more vulnerable. According to that, we devised our surveillance strategy. We evolved our testing strategy based on the emerging patterns of surveillance finding and testing. We went ahead with putting restrictions, which we call as containment on micro-containment zones. We ensured its effective implementation. Most importantly, we went with stakeholder involvement. We made proper engagement with community. We pulled in best practices and ideas from various stakeholders in a marathon session of webinars. And all this was done in the preparatory phase. And simultaneously, we worked on strengthening our health infrastructure. The next graph gives a quick glance of how the epidemic curve has been in Trivandrum district. As you can see that we had a first case somewhere in March, 13th of March 2020. For the first 4 months of the epidemic, we were able to keep our numbers low. Previous slide, please. And for the next 4 months, we had our numbers increasing, but it took us almost 8 months to reach the peak. I feel this has been a good achievement because it gave us 8 months of time to prepare. We remained for a very short period, less than 13 to 14 days at the peak. And then we entered into a declining phase, and then we have been plateauing since then. Next. The objective of the strategy. The objective of our strategy has been to reduce prevalence of moderate and severe cases in the community, to ensure that we have effective reverse quarantine. This is because that 15% of the population of my district are 60 plus and above, and this is an important set of population which are vulnerable to the virus. We also worked with an objective to reduce the CFR, and simultaneously we enhanced our critical health infrastructure to meet the surge capacity. Next, please. So touching the topic of surveillance, this is how we had divided the district into 5 zones, depending how the vulnerability is present in the district. The coastal zone is a 76-kilometer long ribbon population, which is highly populated and has its own set of challenges. The city area again is a small area with very high population. Rural area has another set of challenges. Although the population is scattered, but the role of community and the role of local bodies become more important. We also had a challenge of interstate border. So we specifically focused on the mobile population in that zone. And lastly, the tribal and the hilly region, which comes with its own set of challenges. In these surveillance zones, we planned our different strategies. Our mainstay had been RT-PCR testing, which was increased many-fold from the month of March till the month of October, November. But in early July, we decided to introduce the rapid antigen test, which was a watershed movement because we immediately jumped into detecting more and more number of cases, and our testing capacity was increased 5 times. In the testing, our focus has been that all the primary contacts and all the secondary contacts will be identified for a COVID positive patient, and amongst them, all the high and low risk contacts, primary contacts, and the symptomatic secondary contacts will be definitely tested. We also ensured that all the 100% ILI symptomatic patients walking into any private or public clinic are definitely tested. Another step that we took proactively in testing is that we tested 3 rounds in old age homes. As I said earlier that we have a high vulnerable population. We have 52 old age homes in the district, and we have completed 3 rounds of testing, proactive testing for them. Beyond this, we also went ahead with outreach testing sessions with mobile testing teams and step kiosks. This gives an idea of how our testing capacity and testing numbers in absolute terms have been. As you can see that from June, we had been testing 11,000, and in July, we tested around 54,000. You can see the graph of TPR rising. It rises up to September, October, which was the festive period. It was an anticipated surge, and we had been preparing for that. And in the last 4 months, you can see, although the number of tests have been quite high, the TPR has been consistently following. Next, please. The next topic of concern is contact tracing. We began in the month of March itself. We had a centralized contact tracing team, which was a 25-member team. We tracked up to secondary level. And the focus initially was in identifying, detecting all the unlinked cases and preparing route maps for them with time-stamp preparation. These route maps were made available to the public. They were in public domain, and the people were encouraged to read them, to understand them, and decide for themselves whether they have been exposed at that particular day, at that particular time. This, in fact, helped us in engaging with the community directly in the initial days of the epidemic itself. Later on, around the month of July and August, we have been extensively working on capacity building of the peripheral health institutions, primarily the primary health centers, to learn the contact tracing. And now, in an effectively decentralized manner, the contact tracing is happening. Our guiding mantra is still testing, tracing, and isolation of all the contacts. Next, please. So the testing, surveillance, and contact tracing strategy helped us to very quickly identify emerging clusters. All the possible clusters are identified and by the presence of unlinked cases, and we could take decisions of the potential spread the disease that might have. The focus has been breaking the chain of transmission. As we all know, every existing infection gives rise to a new infection until the chain of transmission is broken. So effectively, we have been declaring containment and micro-containment zone, geographically reducing the mobility and trying to break the chain of transmission. Next, please. The last step in our surveillance strategy is quarantining. Given with the WHO guideline incubation period of 14 days, the quarantine period of every contact, primary and secondary, is 14 days as per the state policy in the district. We'd ensured the home quarantine is effectively monitored, and this was done with the help of local self-governments, the ward level monitoring committees in the rural areas, and most importantly, the resident associations, primarily in the urban areas. We had given equal focus to home quarantine and also made available the choice of institutional quarantine, government unpaid, to the public as per their capacity. The challenges, if I may have to sum up for the district, are that being a capital district with being a railway hub and an international airport, we had a very high mobile population. We have to ensure that the screening is strict, identification of people are properly done. We are a border district with a state which had entered into a surge much before us and also had a high TPR. We had an inflow of population from that border, which was always a challenge. I already mentioned about the high elderly population and the long coastal area with dense population. We also have the seat of power of the administrative power in the state, and hence strategically important state offices and even Government of India offices are located in the district. The strategies, we have been focusing on timely declaration of mobility restriction in order to break the chain of transmission as quickly as possible. We have been using technology to ensure there is strict screening and quarantining for the entire incubation period, targeted testing, as I explained earlier, and most importantly, the involvement of all stakeholders. Next, please. In the involvement of stakeholders, in the month of August and September is a popular festive period for the entire state and also for the district. We went ahead and engaged with all the stakeholders, youth, resident association, businesses, private hospitals, doctors, enforcement agencies. We took ideas from all of them. We held a series of webinars over the period of 3 days. And the purpose was that the community is sensitized of what is their role in order to the anticipated surge which is likely to happen after the festive season. This culminated in bringing out a Trivandrum action plan. And this was quite successful in terms that we were expecting a surge to happen immediately by second week of September or so. But we were able to postpone again it by 4 weeks, and we hit our peak only somewhere in the mid-October. Next, please. Lessons learned or what worked for us. I think a unified command center, very clear decisions, daily review and planning, and very effective percolation of these decisions to the frontline healthcare workers at the ground level. Stakeholder involvement, basically making public a partner and making them aware of their responsibility and accountability. Achievements, if I'm allowed to say so, is that we were able to postpone the peak by 8 months. Why I consider this as a success or an achievement is because it helps us to give time to prepare our infrastructure. It gives time for the medical management to be more stable, to be more mature, so that deaths are less. It helps to prepare the critical health infrastructure in terms of ICU and ventilators. It keeps the motivation of the frontline worker high, and it reduces the fatigue. I would also like to say that we stayed at peak only for 13 days, which was less than a fortnight, and we were immediately able to come out of it, and we are right now in a plateauing phase. These are some of the glimpses of the activities taken under the IEC campaign in ensuring that there is a behavioral change and people are made a partner in this entire process. In the end, I would like to say that brick by brick, we built a fort to stand the test of time. It is only possible that because we had sound guidance and hand-holding from the state, and the teamwork is what we have been able to demonstrate the successes or achievements which we could have in a short time. Thank you everyone for a very patient listening.
Thank you, Dr. Navjot, for giving us an overview of your activities in the district. And yes, we can see that a very strong fort has been built by you and your team, and we hope that it will definitely stand the test of time. Now, let us move on to our next speaker, Mr. Suhas, who's the District Collector of Ernakulam. He'll be speaking on the management structures and innovations. Over to you, Suhas.
Very good evening, everyone. I'm District Collector Ernakulam. I'll be focusing on innovations in management structures in our district. This is the profile of our district. Firstly, I would be explaining as to why Ernakulam district is very important for COVID management. Kochi is economic capital of our state. It is the gateway to other parts of Kerala, hence it's very well connected. We have a seaport, airport, and trains which are well connected to different places in the country as well as to the world. There are tertiary care private hospitals which are catering to international patients for medical tourism. So basically our district is a medical hub for international tourists. We also have the largest migrant population in our state. It's about 6 lakhs. We have the largest old age population in our state, and we have a very long coastline. Unless there is a robust COVID-19 surveillance, containment and management system, there is a risk of Ernakulam being an hotspot as well as epicenter for transmission of COVID-19 to other districts. This is how our COVID-19 war room looks like. Our experience in 2019 Nipah outbreak in Cochin guided us in designating these nodal wings. Officers assigned to each of these nodal wings was reporting daily activities to me at 6 p.m. Interventions were done as per the daily assessment. This level of management structure helped in quick facilitation and effective utilization of available resources. This is the broad contour of innovations in our district. District level innovations were made so that along with combating COVID-19, non-COVID challenges would also be managed and continuity of life and general administration would be smoothly facilitated. Firstly, I would like to talk about innovations in sample collection and sample management. The biggest challenge which we faced in the beginning of pandemic was ensuring timely collection and transportation of quality patient specimens. So we introduced a device which we named as WISC, that is walk-in sample collection kiosk, which would facilitate collection of patient specimens minimizing the use of personal protective equipments and rationalizing HR deployment and space constraints. With the encouragement from the state health team, we improvised on it and used it extensively in our district. Our second innovation was deployment of designated mobile collection teams. Basically, bedridden and elderly pediatric population who could not be brought to collection centers would be catered to by deploying these DMCTs. And the third innovation is setting up of district mobile medical units, which we called, which was popular in our district known as MMUs. This was for catering to COVID and non-COVID health needs of vulnerable populations in the district. This includes geriatric, pediatric, and palliative patients in the district. Innovations with respect to patients management. Ours was the first district, as per the instructions from the state health department, to set up domiciliary care centers for asymptomatic COVID-19 patients. Some asymptomatic patients who ideally should have been in home isolation, but who were not having facilities at home, were provided domiciliary care at DCCs. These were set up in all panchayats in our district. Second was FLTCs, popularly known as first line treatment centers. As per the directions from the state government and the state health department, it was first tried out as a pilot project in our district, and eventually it was extensively employed in other places. This was set up for patients with minor symptoms, that is category A, who need not be admitted in COVID hospitals, but they were provided with medical care in FLTCs. The advantages being, it prevented the exhaustion of resources in designated COVID-19 hospitals. It also ensured the care of COVID-19 A category A patients at peripheral level itself. Another innovation was, after the success of DCCs and FLTCs, we also got instructions from the state government and state health department with proper guidelines to set up second line treatment centers. COVID-19 patients with moderate symptoms, that is category B1, who could be managed at second line treatment centers. The main advantage here was that we could deploy additional beds with sufficient facilities at peripheral levels itself. This reduced the load at our main COVID-19 hospitals. One more initiative was Karmibot initiative. Patient services like delivery of food and basic amenities in our COVID hospital were done by using these robots. Advantages was that skilled HR could be redeployed to other areas of patient's care, especially in those areas in peripheral. Second one is integrated supply initiative. Pooling up of CSR funds and from other like-minded departments for integrated supply of PPEs and other required medical supplies in the district. The main advantage was that COVID-19 safety protocol could be met in resource-limited healthcare institutions and in other public sector departments. One big achievement which I would like to highlight in our district is setting up of state-of-art COVID-19 Apex Center by taking over and upgrading a hospital which was shut down. PVS Hospital, which was shut down for many years due to a legal dispute, was taken over under Disaster Management Act and was made functional into a proper COVID-19 hospital within a month. So this helped us save many lives. Another achievement which I could state by our health team in our district is Care Platform. It was an open source in-house platform which was known as Care. It was developed for COVID-19 patient management and also monitored COVID-19 transportation to designated care centers. The main advantages of these two facilities which we created was that we have had case fatality rate of only 0.34%, even though we have had more than 1,20,000 COVID-19 patients till date. The figures, I think, is unmatched anywhere in this world. This is only because of the support given by state government and the state health department, along with the health department in our district, which made it possible. It was using these two systems that we could manage ICUs and ventilators in a good way in our district and ensure that our COVID management was somewhat successful. Finally, to make sure that life goes on uninterrupted during these challenging times, we introduced following innovations in our district. And all these innovations would not have been possible without guidance and support which we have received from State Health Department in Trivandrum, and also all kind of leadership and support which we received from the state government. And also, I must say, our health department in our district functioned very well during these troubling times and ensured that it was a solace to people of our district. Thank you, sir.
Thanks to the ignited minds of Ernakulam, we could find many replicable practices in the fight against COVID. Thanks for the talk, Mr. Suhas.
Thank you, sir.
Now we'll move on to Wayanad, District Collector Wayanad, Dr. Adila. Over to you.
Hello, everyone. I think two of my colleagues have now spoken in detail about what was the management done during the COVID. But I have a different story to tell because Wayanad is a district which is has 80.5% of tribal population, and we border with 2 states, 7 districts, and if you look at the health infrastructure in the state, we might be the least district with least health infrastructure. So COVID was kind of a challenge for us. We had to manage a lot of people at the borders. Being a small district, we had to manage around 55,000 people in the quarantine. And we could also had to just look at what our health infrastructure was, how we could improve it. And yes, we had to trace all the tribal people and bring them home safe. So basically, it was not just a health initiative that we had to do. It was an integration of many departments. And yes, the challenge was to take it forward and take 3 months at least when the other districts are peaking. Sometimes we thought if we depend on the other districts, we always had to wait till the other districts peaking was over. And we had been successful. The peaking in Wayanad district just came in the late January and early February time. The topic given to me is to speak about the care and support given to the departments and people. And the 8 lakh population, Wayanad has 8 lakh population with 18.5% of tribals. The initial phase of the pandemic, yes, we have to act early, act fast. We had to be well coordinated because there was a challenge in, there was remoteness, challenging getting connected. But the success, if you ask me, I would say was a very decentralized management. There was community ownerships. The local self-governments were fully made to take up the challenge, even if it was to declare a containment zone. The local self-governments had to sit together for their meetings and then to refer it. And a second thing, what we could do was proper education to the people. So we had a daily press meeting with the media who take the message along. And I think till now we are seeing the benefit of the proper proper people education and the communication strategies taken. The care and support would be divided into the health department support, which we had to give, the community support, which we had to give, The tribal support we had to give, job support, which might look very unimportant, but this has been one major challenge. We had to look at saving the people's jobs. We had to bring back the tourism which the state district was dependent upon. And now we had to support for living with COVID also. If you can look at it from what we have built in the health sector, the green line would show us what is the COVID hospital requirement, the facilities which we have used, but yes, our requirement, we have not even reached 10% of the facility which we have in the health sector. But this whole thing was made during the COVID. We had scaled up the health infrastructure in the district very much with the help of state health department. And we have not used even 10% of the health setup that we have now. And for every disease in Wayanad, we were depending upon the neighboring districts for their tertiary treatments, and we didn't have a medical college or a tertiary care center. But 100% management was done with the help of our doctors and our health infrastructure. And I'm happy that our doctors were given enough confidence that they rose to the occasion, took the challenge, and the local self-government and the community groups and all of us, the disaster management team, everybody supported them in taking up the challenge. Health institutions have improved. Healthcare professionals were supported to an extent that we had to keep so many people in separate facilities here, as we could not even risk one person getting COVID and taking a break, because the healthcare professionals team was also in a lot of challenge. The patient support we had to give, community support we had to give through community kitchen. The infrastructure was updated. We were, in fact, the first district to install an oxygen generator plant in the COVID hospital. The ventilators were increased, the HFNCs were increased, and we had a proper, converted the district hospital into a very proper referral hospital with tertiary care facilities. Care and support among the vulnerables. The mental health support was given, the tribal health support was given, the guest workers had to be supported, the old age homes had to be supported, the physically and mentally challenged had to be supported, the chronic ill and the palliative had to be supported. We had to even supply drugs, collect it, make cross-subsidize the chronic illnesses. There were people who were dependent upon the money given by other people to support for their medicines. That also had to be arranged, which we had successfully done through donated drug campaign. The mental health team was very well taken care by the district mental health program team. So total calls for the admitted patients was 23,515. The total admitted patients is 12,000 for us. Not the admitted patient, the total COVID patient is 12,000 for us. The tribal health, if you look at, only we had 934 tribals only affected. By going by the statistics, the 12,000 statistic, 20% had to be tribes. So only 8% of the tribes, going by the statistics also, the tribal population which was affected was very little, because we had cordoned and taken care of the tribal colonies very well. Now in the tribal health center, we had a tribal full-time cell which was working. We had given special food kits, the additional supplements like cooking oil and firewood. Successful behavioral modifications were made, and the compliance of SMS protocol is in fact better than the general population. There was all medical referrals outside the district was restricted, so we had to manage within the district, which was also been successfully done. There were a lot of laborers which were stuck outside the district's transportation of the stranded tribal laborers also was carried out very successfully. The total tribal patient load is only 984. 2 lakh population of tribes we have. Total tribal death was only 2, which I see as a very remarkable achievement that we have made due to the intervention in the tribal sector. Geriatric population was marked. Their NCD medicines were not discontinued at all. We had ensured enough awareness. And the street dwellers and their jobs were taken care of. Community kitchen was another successful model. It was done through the Kudumbashree units, and it went to all the vulnerable tribal communities and the town areas and the Panchayat headquarters, so that anybody who could not find food could come there and have. And agriculture department had to be submitted, because this is again an agriculture and dairy based district. So that was also taken care of. The vegetables were procured properly. A dedicated call center was there, and the vegetables were taken by the community kitchen for their use. Dairy and animal husbandry, milk was of course the challenge during the COVID times. That was also also taken care of. Cattle and the poultry feed was also supported during the lockdowns, and the dairy sector is still doing very well in the district. Infrastructure is remarkably increased. Entire district machinery worked as a single team. The district was successful in bringing all the essential need to the doorstep of the people. The panchayat were our prime place of management, and they had taken good ownership, and they are continuing to take good ownership. Commercial activity had to be supported and job security ensured. Now there goes a saying that even if you are on the right track, you will get run over if you just sit there. Yes, we have further challenges. We have malnutrition. We are an aspirational district. We have TB programs which had to run well. So yes, we have slowly moved, looking at our other challenges also. And we have monkey fever, scrub typhus, open air park textbook, whatever disease you find there, it is there in Wayanad. So we have been looking at our other part also, and COVID management has taken a good course, and there has been good support, and the district was able to do well. And thanks to the health department, the disaster management department, the local self-government department, and the beautiful leadership of our Honorable Chief Minister for taking the project forward. Thank you.
Thank you, Dr. Adila, for your inspirational journey and taking us through that inspirational journey of support and care, especially being an aspirational district with resource constraints and constraints in terms of geography. You've done remarkably well. And like you said, at no point of time did we feel that you're just sitting there and waiting to be run over. In fact, you're taking long strides, leaving everybody behind. Congratulations and good wishes in the days to come. Now let us go on to the final speaker of today, Dr. Raman Gangedkar, who is the head of epidemiology, ICMR, Government of India. Sir, a warm welcome to you, and we would like to have your remarks on the epidemic and also your comments on the fight put up by the state of Kerala. Over to you, sir.
Thank you for inviting me. Now I'm not currently the head of epidemiology. That's why what I'm going to do is essentially speak on an individual basis based on the available evidences and interpretation as I was asked to. Am I audible?
Yes, sir, you are.
Yeah. Now, one of the first things that I must admit that the entire presentations that I saw actually talked of so comprehensive and such a nice response that I'm sure whatever we document will become part of the history, part of learning, so that other states can also follow well. Perhaps even other countries can look forward to doing things in an appropriate manner. Now, I will just give you a glimpse, very quickly, because I know it's 8:30. So we have been on this VC for a very long period of time. But let's look at what is the current curve of the top 10 countries. You suddenly, if you look at it a little more seriously, you will suddenly see that majority of the country are showing decline of the infection as of now, excepting for Brazil. If you look at USA, which was talked about story, you suddenly find even the third wave is on a decline in USA. You look towards India, you find that our first wave had just about ended at this point in time. Now, what does it essentially tell you? Within a month's time, perhaps the most precious period in the history of this pandemic will start, because you will find that in a month's time, majority of the countries have shown a decline. And if we all work together, perhaps we will be able to contain this outbreak dramatically. But one must also understand certain nuances. One is, when you look at a national curve, it can essentially mask the heterogeneity. The larger the country, the larger is the likely heterogeneity that would be there. And therefore, what are you seeing in a country like ours, which has a huge population to cater and a large geographic size? No, majority of the states, though it appears that they are showing a decline as of now, Maharashtra, Kerala, and Karnataka appear to be slightly different. But when you look at little more carefully towards Maharashtra's daily infections and testing curves, you will find that in Maharashtra, certain pockets are also showing that there could be a potential resurgence pretty soon. Certain districts are showing higher incidence of this particular infection. But if you look at the testing curve tends to show that there is a small decline that is observed, which essentially means the uptake of testing has reduced currently in Maharashtra. When it comes to Kerala, in Kerala, you will find that essentially the first wave itself has been longer. Perhaps it's sustained for a longer period of time. The testing numbers have definitely not declined as much if you compare it with Maharashtra. So it essentially tells you two different stories at this point in time. A stronger adherence to lockdown coupled with a strong public health action may perhaps have prolonged the first wave in Kerala itself. Therefore, what you are seeing is a plateau stage, and this is especially true for a state which has a smaller population size compared to other states. And the more you look at micro geographic areas, more at the districts, you are more likely to find a variation that would stand out against a very large kind of population base. The larger the geographic area, you will find the variations will be seen will be few because it smoothens the curve. The smaller the area, you will find that it appears as higher all through. But we know that at this juncture, newer variants that can spread rapidly and escape mutants that perhaps evade the vaccine-induced immune response can pose additional challenges. Why do these escape mutants develop? We need to remember that SARS-CoV-2 tends to mutate very slowly compared to other viruses. If you look at the transmission dynamics, it is coming as a surprise. The sole reason is the life of this particular virus is short enough, and we do not have the selection pressure of antivirals because there are no specific antivirals that are available. But it is perhaps the immune response that may be impacting the generation of variants. If you look at that, there are two possible reasons why mutants are coming. The repeated use of convalescent plasma, perhaps you are exposing the virus to multiple neutralizing antibodies, and the weaker ones tend to be the ones against which perhaps the virus is able to produce quickly the escape mutants. And infection among immunocompromised hosts is also a critical issue because the duration of survival of this virus may be longer in those patients, and therefore you might give an opportunity for this virus to mutate. Do we know enough about these mutants in India? The genomic surveillance that was started by ICMR in March 2020, it has been expanded now. The large caseload tends to preclude ones from making a statement that, yes, I know enough. The larger is the uncertainty in this particular situation. Some early evidences tend to emerge, and they tend to show you that some of the vaccines may not work against it. But is that going to be a big threat for us? Perhaps not. Now you look at UK, where the variants tend to be more commoner, you find there is a huge decline that you are currently seeing in terms of epidemic curve. You look at South Africa, a dreaded mutant which is located in South Africa, even that has got a decline at this point in time. You look at Brazil, Brazil tends to be the worry, but if you actually look at it, the proportion of people who may be traveling from Brazil to India continues to be low. So the risk perhaps depends on our own practices, because we need to ensure that international travel related guidelines, which were made more stringent recently, needs to be adopted really well. We can still prevent and restrict the entry of these mutants, but our worry should be essentially towards use of convalescent plasma. If we can reduce that, perhaps mutants that could be generating in India can be reduced to a larger extent. And we also need to remember that the more number of cases the virus will infect, it's like a passage that tends to occur in a laboratory, the more is the likelihood for the virus to mutate. So we need to curb the rise of numbers at this point. Now, the bigger challenge is sustaining the COVID appropriate behavior. If you look at IHME data, you find that in India, the overall mask use has dropped from 71%, which was seen early in the outbreak. You are finding it now to close to 64%. You look at the reduced mobility, you find earlier it was minus 42%. Now it has gone down to only minus 23% because the mobility has increased. Lifting the lockdown perhaps puts you into a crucial phase at this juncture, especially when schools and colleges are being opened. What we need to understand is one jacket does not fit all. There could be differences in levels of outbreak in smaller geographic areas, the size of social network, the adherence to COVID appropriate behavior, and the quality of implementation of strategies is likely to be different. And therefore, decentralized approaches are going to work well. Now, if you think in terms of decentralized approaches, the decentralized approaches could be for implementing one or more of these appropriate strategies depending on how the outbreak is occurring there. One needs to monitor opening of schools and surveillance, colleges, one needs to have a surveillance in place, and one needs to find out evidence of spread for immediate appropriate measures, including closure of such institutions temporarily. That's going to be critical. If we don't do that, the spread of the outbreak is likely and may eventually lead to endemic infection occurring in this country. Now, we need to promote COVID appropriate behavior, especially among migrants, as a major challenge. Most importantly, we need to make all efforts now, given that the outbreak is going to be most declining within a month's time all over the world. The strategy would be more focused on what we know: test, trace, isolate, and treat, and additionally, the vaccines itself. For tracing, there is going to be one more major challenge that will come. As it moves to younger age groups, you might find asymptomatic infections are more likely to be common. Given the nature of infection or even the younger age, we need to ensure that we need to have differential approaches to ensure that those who need testing get themselves tested. And that may perhaps also point us to one fact that contact tracing will have to be an entirely different approach, which needs to be more intensive at this juncture. What is also important, people tend to worry about use of antigen testing, but use of antigen testing has also an advantage, though it might also have a disadvantage to some extent. One must remember that since this test can be offered very quickly, you will find that it may reduce the secondary infections that could occur from this index case, because you tend to pick up the secondary infections tend to occur 2 days prior and 2 days after being symptomatic. And if I can even cover 1 or 2 days gap, it makes sense in order to ensure that the transmission comes down. Tracing is going to be a challenge, because you need to remember, when the numbers increase, it becomes very difficult for any public health department to ensure that the tracing occurs properly. There would be an important role to the index case himself or herself and the social network to actually announce and ensure that they come forward for testing themselves. One needs to isolate. I don't need to discuss more here. We understood all the strategies that you have implemented. What is important is, traditionally, we as Indians tend to have an isolationist approach. Anybody who is sick perhaps tends to be isolated very quickly. And the result is, you will find that it can impact the spread of an infection. Vaccine acceptance is vital, but in view of the variants that are emerging, rapid vaccination is going to become vital. Even the herd immunity level that we need to achieve is likely to be far higher. What needs to be strengthened is community mobilization. And for community mobilization, group-specific communication to promote COVID-appropriate behavior and its adherence need to be in place. Peer-based approaches for information and adherence are vital. We need to involve key opinion leaders from different strata. One leader cannot be considered as an opinion leader for the entire population as such, even within given geographic area. There is a room to develop an ideal demonstration field site, which would have complete package of intervention, including vaccines, which can be used to showcase as to how to control this infection. Finally, we need to recognize that maintaining health of people is not only government's responsibility, but we need to inform the community that it is also of the individuals and the communities itself. One can only become safe if others to whom he or she can be exposed as well are safer. In the modern era of high mobility, our safety also depends on safety of others, however their usual place of residence may be distant. Thank you.
Thank you, sir, for your talk. You have emphasized upon the decentralized approach with the local strategies in management of COVID. You've also emphasized on the back to basics in COVID management and also on the utility of antigen tests to pick up early infections. And ultimately, as the saying goes, your health is your responsibility. So everybody is a partner in the fight against COVID. Thank you very much for your talk, sir. And we also look forward for your guidance in the future as well. Before we formally wind up, there are two questions which has come. That is for the District Collector of Trivandrum as well as District Collector of Ernakulam. A question first to Dr. Navjot from Dr. Anil from Trivandrum. He asked, as a DC, you're always playing with fire day in and day out. How does your team remain motivated in this long drawn battle?
Thank you for the question, sir. So in any kind of crisis management, I believe it's not the individual's performance that matters, but it is how the team operates. I think having a flat structure, consultative decision-making is what actually helped us to ensuring a voice to everyone, taking feedback from the field, be it the political representatives, the panchayats, the frontline healthcare worker, the Anganwadi worker, the Asha worker, police, the constable on the ground. Everybody's feedback is very, very important. And to keep them all motivated, sir, I think we actually, as a district, entered into the peak. We were the first district to enter the peak, and being a capital district, I think it was a lot of emotional response to it also, that everybody took it as a challenge. We ensured that everybody's ideas are brought to the table. It is consulted, and dynamic decision making happens. Everybody's voice is heard. And I think this ensured that the team will either swim together or will sink together. Hopefully we are swimming out of the epidemic and we have entered into the vaccine stage.
Thank you, Doctor, for that response. Now we'll move on to District Collector Ernakulam. This is a question from Ms. Rekha. She asks, how did you manage the challenges of the migrant population?
Thank you so much for the question, sir. We had a very big challenge because we had the highest population of migrant guest workers in our district. Well, our first challenge was ensuring that community kitchens were established in every migrant camp so that they were well looked after. And also every day in our DDMA meetings, we ensured that topic of guest workers was discussed. We had a committee of labor department, police department, and also revenue. And the third thing and the most important thing was setting up of labor call center in the collectorate. About 50 youngsters drafted from guest workers themselves who knew 5 major languages like Bengali, Odia, then Hindi, etc. were drafted, and they were given duty in our call centers on rotation. This ensured that proper information was spread to the guest workers, and also that they did not get carried away with false information. And based on our preparations on the ground, and also due to encouragement given by the state government as well as health department, the central government selected our district as the pilot district for sending the first Shramik train to Odisha. We sent 1,700 guest workers to Odisha. Over the period of time, more than 85,000 migrant guest workers from our district were sent to different parts of India who were willing to do so. There were a good number of them who stayed back and we were well looked after during the entire lockdown period. So and we also facilitated their return after some time. So this was a challenge, but it was well met due to the great teamwork which we had in our district, and also due to the support which the state government gave us. This is about it. Thank you, sir.
Thank you, Suhas, for your response. Now it is the time to conclude this session. We've had a wonderful talk by all our speakers. And on behalf of Kerala Health, I formally thank Dr. Navjot, District Collector of Trivandrum, Mr. Suhas, District Collector of Ernakulam, Dr. Adila, District Collector of Wayanad, and Dr. Raman Gangetkar, who is, though he claims that he is not still working with ICMR, but sir, you will always be ICMR for us, and we look forward for your guidance in the future as well. So the takeaways for all of us in this session is back to basics. And as the tagline of Kerala Health goes, your health is your responsibility. So I thank all the panelists and all the speakers and for all the questions that has come, which has made the session very interesting. Now I formally hand over to Dr. Indu to conclude.
That brings us to the end of second webinar on COVID-19 pandemic, health system response, resilience, preparedness. Thank you very much for joining us. Signing off for the day. Let's meet again. Please join us for the next in the webinar series, Achieving SDGs related to maternal mortality and infant mortality rate, dream or a reality, which will happen on 24th February. Goodbye.
Thank you.